Well, good afternoon. Thank you all for joining us. It's a delight to see so many folks in person, and thank you all who are joining us by Zoom or Teams or however you're joining us. We always are interested in other clips that you'd like to play in advance. So feel free, send links for the spring meeting. This is our agenda for today. And so today we have Drs. Linendorf doing the prostate organ site, followed by Drs. McConkey and colleagues who are doing TM, and Peter Van Velsizen, who's speaking on cancer control. And then Saturday we have our other schedule. Was Sam in here, Sam Callis? He's not here for his introduction. Well, this trio that you see here, Kathy, Melissa, and Gabby, are the folks that really make it possible. So applause. And walking in the door comes Sam Callis. Please welcome Sam, who is just joining us as well. Just to put it in perspective, we have one of the largest and most successful statistical teams. We couldn't do it without them. We love you all very much, and thank you for doing that. Here are our TM colleagues. James and Dan. I think James is not here. Dan did the symposium this morning virtually. Our imaging colleague, Scott Lucia, also is not here today. Colin Denny, who is our liaison to the spores, Niraj Agrawal. Peter, who helps us interface with cancer control, does a fabulous job. And Jessica McDermott, who is our diversity, equity, inclusion representative, who keeps us on task and helps us with this. Our oncology research professionals, as you see here, our data coordinators, and for all of us, we understand that while our statistical team and operations office are so important, it's truly our data coordinators and our CRA liaisons that make us work. So we're very grateful for the work that they do. In pharmaceutical sciences, Joyce and Rivka, and our patient advocates, Rick Bangs. This is an old one. We'll update that momentarily. And Tony Crispino. I didn't see, is Tony here? Tony, is Tony here? Due to arrive. And you probably saw.
I'm on remote.
He's on the line. Good. Thank you, Tony. Good to hear you. And Taj is leaving SWOG. And for the temporary, we'll talk about this momentarily, Dana Sparks in the operations office will be subbing in. So we have a superb sub until we're replaced. So it's D Sparks at SWOG.org if you need to get in touch with her. We're very grateful for Taj. He's a terrific guy, and we will miss him, but Dana has assured us that we will have high priority for someone who is as good or better than Taj subbing in. Our organ site chairs, who really are the brains of the group, Tom and Seth and bladder, and Tanya and Dan and prostate, and Ulka and Brian and renal. If I read my email correctly, I think Brian is unable to be here because one of his kids got sick, and so he's back minding the shop. But I think he may be on as well electronically. Here are our registrations. You see we popped up a bit. And then the last year has been a bit lower, which is one of the items that we'll be speaking about throughout the meeting, thinking about concepts that will boost our registration, our accruals. One important thing I'd like to highlight for all of us is the HOPE Foundation. We have lots of direct research support. If you've never been to their website, I would encourage you to go to the HOPE Foundation website, cruise around it, because the number of opportunities for senior investigators, but more importantly for junior investigators, is really tremendous. They provide us support for a lot of the things that we do. There is a young investigator training course, and Deepak back here in the back, you saw his, if you were in the plenary, you saw his smiling face in the back as he was up in Seattle for the young investigator training course, working on the small renal mass protocol. So congratulations to you, sir. This is how HOPE helps us develop the leaders of the future. Earlier today, we were spending some time honoring Nick Vogelzang, who, as I think all of you know, passed away just recently. Nick served the GU committee between September 24th of 07 to September 30th of 21, 14 years as the vice chair. Nick had an enormous impact. He conceived studies, he helped them get designed better. He helped enormously in accrual. He would always comment on studies when we were together and during our monthly conference calls. He mentored a lot of junior investigators. Can I just show of hands, anyone that Nick ever touched and helped you in your career, would you raise your hand? You know, it says something. And so that's probably 75% of the people in the room. I would challenge you to think about anybody who's had that magnitude of an impact. And I would contend his mentoring helped us to be better mentors, so we helped others. So it's a bit like, I guess, you know, the Beethoven who trained those who trained those who trained those. He also supported a lot of senior investigators. And the most important thing he ever did is he never did much for himself. He always did for others. So we honor him. He passed away on September the 20th. This is the picture of Nick and his brother, Mark. Nick had 5 brothers, and I think, I don't have a picture. I think I have some pictures momentarily. Very large family, very accomplished family, lots of folks with remarkable accomplishments. His wife, Diane, survives him, as do kids and grandkids. And this was taken just the week before. Nick was a remarkable guy. We have the opportunity to honor him 2 ways. We have established the Nick Vogelzang scholarships, and the executive committee this evening will be discussing how that selection process will happen, but it's going to be to support young investigators. And why I have singular young investigator, it probably will be multiple. So there will probably be in pairs or more that will be identified. They'll be helped, they'll provide funding to come to the meeting, the expenses at the meeting, mentorship. They'll be assigned a mentor for at least a year to help them get started in SWOG. We hope to release those details for the application in the next few weeks, and we hope to announce the first Vogelzang scholars before the end of the year, or right after the end of the year, so that those first Vogelzang scholars can join us at the spring meeting. And this morning, thanks to Parminder and to Seth and to everyone else who helped put together the first Nicholas Vogelzang Symposium. For those of you who are new to SWOG and the GU committee, those symposia have led to at least 2 important, I think perhaps even 3 important large-scale phase 3 trials. A bit like a NCI consensus conference where everyone came together, talked about the science, led to the development, and launched those trials. So it's only fitting and appropriate that Nick's name be on that. We have the opportunity to honor him, and earlier today in our symposium, there were some flyers. I'll make sure we have the flyers, and there's a QR code that you can contribute to that. And I know many of you have already done so. We're very grateful. Enables us to give back. There's pictures of Nick and 4 of his brothers on a bike race. There they are again. And that's the QR code. We'll make sure that we get you some of those today. Now we also have the opportunity. Peggy Zuckerman has retired as she has become emeritus, right? Emeritus patient advocate. And our newest member of the GU committee is Laura S. Feller, Laura, would you stand up, please? And so we can welcome you as the new renal advocate. So we're very grateful. And she's already like second cousin to us, right? Because she served as a DOD reviewer, Kidney Cancer Association grant reviewer, and all of these. She participated in S1500. I think I remember that conversation that you were, when they had the patient age range, you were over here, right? That was you. And just look at her today. It's just absolutely fantastic. And I would encourage you to read her post, The Oncologist who Saved Me. I think it's hashtag single white kidney or something like that. It's a wonderful post about her relationship with Nick and with others. So just one last housekeeping reminder. If you're considering serving as a study chair, there are conflict of interest policies. Please read those. If there is a amount that exceeds $5,000, a management plan is instituted, and if the amount exceeds $10,000, so if you're coordinating a trial that involves a drug that is on the trial and you receive more than $10,000, you can't serve as a study chair, so please don't put us in that position. If you have any questions, just send Dana Sparks an email. And finally, to receive email notifications about what we do, please make sure that you're a member of the committee. And it's fascinating when we're not really sure. If you just send an email to the ops office, protocols at SWOG.org. Normally you'd send it to Taj, but send it to protocols or send it to Dana Sparks. We can make sure that you're you're a committee member, because we want to keep in touch. And finally, let's all stay on time. And I have the pleasure, here comes Lori Manassian, who is with the Division of Cancer Prevention. Lori has been a friend of SWOG, for a long time. She helped with all of our prevention trials. Lori is one of the bright lights in Washington, and she's going to tell us a little bit about the new well, I'll just leave it up to you.
Do I just, oh, this is,
Okay. Yes.
Thank you for inviting me, Ian. It's a pleasure to be here. I'm here to spend like 2 to 3 minutes talking about the new Cancer Screening Research Network. This is going to be, we have posted formally a public notice of intention to publish funding opportunity announcement. So this is a head start. This gives everybody about a month to look at what the requirements are. We will have about 10 to 15, depending, accrual, enrollment, and screening sites. These are sites with multidisciplinary teams of investigators with screening expertise who will be responsible for recruiting to the trials. There will be a coordination and communication center, and separately a data statistics and data management center. The prevention.cancer.gov/cancer screening, or Google NCI Cancer Screening Research Network, and you'll get to it. The structure of this new clinical trials network, which will use the CTSU and all the standing infrastructure we already have for NCTN and the cooperative groups and the NCORE program. This is what it will look like. It's because there's only one coordinating and communication center and one data management center. The steering committee will basically run the whole network. We are looking for different kinds of healthcare sites, academic centers with outreach programs, healthcare systems, practice-based networks, community sites are all welcome to apply. As you all know, and we heard at the Nick Vogelsang symposium this morning about the promise of the circulating DNA blood assays or urine assays for measuring minimal residual disease or measuring circulating DNA for specific markers. It's being used quite well in the treatment setting or after you've had treatment. And there are many assays coming forward that are looking to screen asymptomatic persons for cancer. There's no systematic way to evaluate them. And so we're starting the network to do just that. The first thing out of the gate is a Vanguard study, a pilot study, where we'll start with 1 or 2 assay companies and we'll basically randomize for purely operational logistics outcomes so that we can refine our assumptions for how to do these kinds of studies in a very large scale. NCI's run cancer screening trials before. They've been primarily outside of the cooperative groups. There have been a couple more recently in the cooperative groups, but we find that an infrastructure that's really dedicated to this has been far more successful in rapidly accruing and completing the trials. So this is the Vanguard study. And I want to leave you with this image of all of these assays basically inundating us with the claims that they can pick up all kinds of cancers in asymptomatic patients. We need to systematically evaluate them. We need outstanding investigators who know how to run clinical trials and understand how to recruit patients. And so I'm hopeful that you and others at SWOG will consider applying. And thank you, and I'm happy to take any questions.
Any questions for Lori?
Asking for a friend. Can the coordinating center and the data center be located at the same institution?
They don't have to be.
But they could be.
They potentially could be,
Okay,
yes.
thanks.
So those are screening studies. Are you expecting the patients will be approached by primary care physicians or by oncologists?
Say that again?
Are you expecting that patients will be approached by primary care physicians or by oncologists?
Not necessarily oncologists. So we're looking for teams of investigators that include oncologists, primary care, urologists, GYNs, et cetera, so that the asymptomatic patients can be basically recruited wherever they are. But we also know that the diagnostic pathway for these unusual assays may be different and will require some level of oncology expertise. So we're looking for multidisciplinary teams of investigators to run the full scope. The network is not being set up to evaluate these assays for recurrent disease. So it's not really looking at these assays in a treatment setting, rather in a setting for screening for new cancer.
Right, because I think in the academic centers, you may have those multidisciplinary systems where, it's one site has the primary care, but in the community, you talk about multiple different sites. Typically, primary care, general medicine clinics are not part of SWOG when the cancer center is. So how do you envision that's going to work?
Well, that's incumbent upon the groups to figure out. What our goal is to incentivize investigators to work together with primary care docs. This actually provides resources to those institutions for that purpose.
So do the primary care docs have to become SWOG investigators then?
The primary care docs, so this network is a brand new network. All investigators will be investigators in the CSRN, including the primary care investigators.
Great.
Thank you very much.
Thank you, Lori. So away we go. Tanya and Dan, thank you, Lori, for taking the time. Lori came specifically over from Washington to tell us about this.
Just saw the first slide. Well, good afternoon and thanks and welcome to the prostate section. We've got a pretty packed agenda. We might need a slide version issue here, but we'll work that out as we go. So I know that we're usually in a round table so we can see each other and talk in the mics. So feel free, there's 2 mics up, and please, if you have a question, just get up right away, and we're happy to have that interrupt if you need to. So we had a really nice session this morning for some of you that couldn't make it, but we had a kind of off the books prostate brainstorming session for about an hour on concepts in the future, as well as some things in development. So it was really exciting, and I really appreciate everyone that could make that. And we'll make that we're going to plan to try to do that at every group meeting. So in the spring in San Francisco, we'll have that worked out. So here's our agenda. We'll have some progress reports for the current trials. We're going to have about an hour and 15 minutes, and then some new and coming soon trials. You'll see there Heather Chang and then Paul Korn. And then we'll have the standard litany of champion trials, and then we're going to end, if we have time, with at least 2 or 3 newer concepts. And here again, in the spirit of SWOG, I'd like to have a nice interactive session and critiques on these new concepts. So I'm going to start right out with Brian. So we'll start out with an 1802 update. Are we good? We'll find out. Okay.
Hopefully, because I don't. Well, good afternoon, everyone. It's good to see you all in person. Real brief, as you mentioned earlier about Dr. Vogelzang, I met him in 2014. We got on a cab together in Brazil. I knew who he was, so I asked him if he wanted to split a cab, and then I pitched him this trial. So just so you know, things happen fortuitously. So as you all know, this is the SWOG 1802. It's actively enrolling. Randomized phase 2 of best systemic therapy, standard systemic therapy with or without definitive treatment of the primary with a overall survival endpoint. Of importance and something we should be, again, familiar with and aware of is that we do have some secondary endpoints built into this. Surgical excision, intent to treat group only. So looking at this also just from a surgical question, not from a surgery and radiation standpoint. Looking at symptomatic local progression, PFS, metastasis-directed therapy, as long as it's given prior to randomization, and then the biobank, and we'll talk more about that, I'm sure, later with the TM session. This is where we are at this point. So 600 and, I don't know where it says it there, but 602, I think, was the last I saw. As you can see, it's fluctuated, and part of that's been in response to COVID and all the issues we've been dealing with staffing of sites and putting patients on trial. You can see the leaders there, and there are some new leaders that have been coming up, and so some sites have still opened this in the last 24 months, and we have a fair number of new kind of leaders in the enrollment there. I wanted to share this because people do ask frequently about where we are with as far as high and low volume. As you all know, with Stampede RMH coming out several years ago, impacting or potentially impacting our low volume accrual. We are at 42% of patients are low volume and 58% are high volume. As far as the treatments selected or identified as what the treatments will be intended to be, 60% radiation and 40% surgery. Very few have actually had metastasis-directed therapy as part of their treatment approach. And then along the lines of the DEI work that Jessica's been doing, I did include race at the bottom there. Many of you are familiar with the enrollment aids we have. We have the CME video on local therapy and metastatic disease. We have a patient education video that can be used in the clinics. And then the protocol-specific materials that are available for the physicians and the site PIs. So my information hasn't changed, it's still there. I'm happy to answer questions whenever they come up. We do get a fair bit of questions throughout the day on a daily basis. One of the things that's come up several times now is with the changes to the NCCN guidelines that have occurred this past year, triplet therapy is allowed as part of the standard treatment approach as we refer to the NCCN guidelines for the standard therapies that are available. I'm going to stop there. Any questions, comments?
Yeah, questions? We have like 30 people on the line, so anybody online, or we have a question here?
To how many patients could have radiation on the trial? I know there was some discussion about that. Seems like perhaps you might be approaching what that number might be.
Yeah, so the limit, the cap on the radiation was 1/3 of the total enrollment.
Yeah.
So we still have about, I think, 150 patients to go or something along those lines that could receive radiation.
Is there any consideration to amend that if we discover we're at a sort of a block at putting patients on the study?
We haven't really talked about amendments being completed, but obviously a consideration depending on how the enrollment goes.
All right, thanks.
Any other questions? Brian, do you want to address the PSMA PET issue about that being a replacement for conventional or not?
Yeah, so one frequent question that's asked is whether or not PSMA PET can be considered for diagnosis of metastatic disease. The CT component of the PSMA PET can show clearly identifiable metastatic disease, then that is sufficient for the standard imaging. If it's PSMA PET positive only, that's not something like a less than a centimeter lymph node and things like of that nature, it does require biopsy confirmation.
Other questions? Really important trial. Great. Thanks.
All right, thank you.
Before I turn it over to Jessica, who's our DEI champion and embedding her efforts in this flagship trial, I did want to give a special shout out to Dr. Mora, who's in the back of the room, joining us from Mexico. They are open and have already enrolled a patient. So thank you. We're really excited to have the Latin American sites supporting this trial. So now, Jessica.
Hi, I'm Jessica McDermott. I am a physician from the University of Colorado in the Rocky Mountain Regional VA, and I was selected to be one of SWOG's DEI champions. Just as a brief kind of overview of what we are supposed to do, we were chosen to work with a group, and so I fortunately got chosen to work with you all in GU. And we were supposed to look through the trial portfolio and find a trial that was enrolling, but not, mostly enrolled, and look to see how we could improve it for DEI enrollment, so diverse enrollments, whether we needed to look at the protocol, where it was open, what we're doing at the different sites to enroll it, and other things like that. So S1802 is a trial that we chose to work on for this specific thing. I'll talk a little bit at the end, but I'm happy to help with other trials too as needed. So some of the initiatives that we've looked at are sexual orientation and gender identification, which I will call SWOG from here on out, data piloting, and then also just enhancing and expanding diverse enrollments into S1802. So the SWOG data right now, as you probably know, we don't really collect that for most studies, and particularly when we're talking about prostate cancer and we're doing local therapy, so things like surgery and radiation, it'd be really important to have this information, especially when we're looking at quality of life outcomes. So what we would like to do, although it's been a little bit delayed, kind of waiting for the vice chair of DEI to be assigned, but he's now assigned and with us, and so hopefully we can start moving forward. But we are looking to pilot this at maybe some of the top enrolling sites for the study, mostly just to kind of look at how we are training the teams, making sure that everyone feels comfortable asking these questions and comfortable explaining to patients why we're asking these questions, and then giving the questionnaire kind of prospectively to these patients. Ultimately, this piloting will be to look at the feasibility of the training and the questionnaires, and then to start looking at who we're enrolling currently. Are we enrolling different sexual orientations and gender identifications, or are we only enrolling a homogeneous group? Then once we kind of figure that out, we can strategize how to have a more diverse group of these folks added to our studies in general, not just this study. And then this can be used in the future to start looking at quality of life and outcome factors. So this is kind of our, pie in the sky idea, but we'd really like to get it started because I think it's really important to look at these things. In the meantime, though, while we're working on all of that, and it's a little bit more slower moving, we also want to make sure we're continuing the diverse enrollments that you guys have been doing. So these slides are, SWOG is really starting to do this for all of the different groups, and you can pull it up or ask for it at any time. It lists all of the trials that are going on and who we're enrolling. So right now, the main things that they have pulled up are race, ethnicity. This is really small. I don't expect you to see it, but the S1802 study is on there. And then also sex and age. Ultimately, one of the goals is to start collecting more data, so having things like the SWOG data and also things like rural urban patients and things like that, so we can really cover a lot of different diversity factors. We already talked about enrollment to date, so we're getting there, but it's been a little bit slower, and so I think that's something that while I'm trying to increase diverse enrollments, I'd also like to help you guys increase enrollments in general. This is the thing that's included on all the SWOG protocols. It's just kind of what we're projecting. So when we're looking at the different race ethnicities, that's something that we're included. And so what we would like to at least meet. That's not too far off when you look at, this is from the 2017 US cancer statistics of all diagnoses. When you look at distant disease, maybe our projected numbers are a little bit lower than that, especially in the Hispanic and Black patients, but not terrible. Again, this is kind of small, but I did want to point out one thing that I think is interesting and something that we should look at a little bit is when we look at our enrollments for this study to just initially enroll and start on the standard systemic therapy, we're doing not terribly. We have 18% Black patients. We have, I think it's 11% Hispanic patients. But what is a little bit concerning is that when we get to the randomization, those numbers drop off, and they seem to be dropping off, particularly in the diverse enrollment. So our Black patients go from 18% to 15%, and our Hispanic go from 11% to 6%. And if that was just disease progression, then I think that would be one thing. We could say they have more aggressive disease. But when we're kind of looking at who goes from induction and then who comes off protocol, they're kind of listed as refusal or unrelated to adverse event or other. So I think that's something that maybe we can look at and see why these patients are dropping off and work with our retention committee to see if there's ways that we can better address that. These are just the sites that are open at which we already saw. But so along with working at the SWOG data, other things that I would like to continue to work on is looking at that retention, as I said, but also one of the DEI champions kind of big thing that they wanted us to do is working with the local sites and how we can help them. So talking to some of the high enrolling sites, see what they're doing that is good, and then helping some of the low enrolling sites and seeing how we can work with them a little bit better. We also thought it might be helpful to start talking to some of our patients, so patient advocacy groups and support groups, kind of figuring out what they know about this trial, why they would or would not, and then also using that as a way where we can ask them how comfortable they would feel answering those SWOG questions, so we can kind of plan for that. So that's where we are right now, and hopefully things will continue to move forward. I would also put a thing out, while that wasn't in our original, I guess, job description to help with multiple studies. As you guys are opening studies, if there's any questions you have or any way I can help, I'd be happy to do that, because it's certainly easier to think about these things up front than it is to try to change the trial like in the middle or towards the end.
This is fabulous work that you're doing, especially this most recent information, because it parallels a lot of other areas of medicine, doesn't it? Like no-shows for appointments, readmissions to emergency rooms and so forth. There's some interesting data on interventions. The federal government just did a big intervention on frequent users to ERs and readmissions because of lack of follow-up. So as Otis Brawley always used to say, race ethnicity is not race ethnicity, it's an indicator of SES. And so it's a testable hypothesis, isn't it? Because if it doesn't change, that would be the results in terms of dropping out. You could design an intervention that is like a social worker kind of person who could intervene proactively. And in the second half of the trial, Brian and Jessica and all of you, you could demonstrate that that kind of an intervention equalizes the capabilities of finishing the trial. I would just say, do it now. We can ask Hope for some help with this, and I'm sure there's an R01 that you could get from that.
Yeah, I mean, that's a great concept. I mean, some of us, I don't know how many have a navigator type system for this, and we actually have it specifically for Black at our site, Fred Hutch Cancer Center. So that would be something. Yeah.
Or Rick's payment for that precedent for helping with transportation.
That goes along with the same lines in terms of infrastructure at institutions. So one of the things we found at our institution was that half of Medicaid patients didn't show up for their colonoscopy screenings. And it was because they couldn't get in contact to change appointments, or there was no confirmation system. So it's something very, very difficult to quantitate, but there may be differences in infrastructure that account for that 36%, 36 patients you talked about before that were not able to continue on with the trial.
Yeah.
So I think that that's a much more difficult question to ask, but certainly needs to be asked.
Great. All right, thank you guys.
Thank you.
Do you want to come to the mic? Sorry, just so everyone can hear. Thank you.
Well, we discussed the issue of providing them transportation or, help with getting to the appointments and things. There was some pushback about whether IRBs would view that, appropriately. So how do we have a actual statement or some kind of official position on that to be able to push back to our IRBs and say, this is not differential or favoritism or whatever it's called at this point?
I mean, I guess that would depend if you have the ability to reach out to a navigator for any of your patients, like whether they're on a trial or not, and just say this patient is having trouble getting to their appointments, then it shouldn't look differential.
Okay, so in addition to the words you use, coercive is the other word that's used. Okay, so there's FDA guidance on reimbursement, and this is the terminology is reimbursement as opposed to compensation or incentive. I think language matters. All right, so if you are reimbursing patients for expenses that they're incurring, that's fine. FDA guidance is behind you.
I mean, like we have taxi vouchers. If we just have a patient that needs help with transportation, we use it like kind of indiscriminately. So hopefully a lot of cancer centers have some of those resources. But I think it will be very interesting in our DEI symposium that Ulka and I held in the spring, that there was a patient who dropped out of a trial for a reason that I think none of us would have ever really thought about, which is she called the phone number on the informed consent and couldn't get through to anyone and felt like she wasn't being, cared for on the trial the way she ought to be because she was, generous as to participate.
Yeah, this is Evan Yu. I'm on Zoom. Can I add something to this conversation?
Sure.
I will say that I think this is very institutional dependent and interpretation dependent. I know there are many institutions that offer taxi vouchers. Some even offer housing. Some have clinical trials surrounding this. I think that's outstanding. I will tell you that our IRB has actually put a statement and a published statement stating that it is okay for us to provide housing, gas, vouchers, et cetera, out there. However, there are still concerns of coercion in two ways, and that is, really interpretation, I believe, of individual lawyers, which is coercion of not just coercing patients to go on to clinical trials. That is a very big concern of some in certain cancer centers and some of the attorneys, but also coercion of the fact that offering these potentially, even if reimbursements, could be viewed by other centers as incentives to steal patients from other centers. And so it's very frustrating because we have many task forces at our center that are working on these issues, but we're sometimes held hostage by interpretation of the law. And so I would love tips or advice. Don't know if we need to start over with new lawyers, but these issues exist at our center.
Thanks, Evan. Yeah.
Some of you may be aware that there's going to be a clinical trials planning meeting in November through the Division of Cancer Prevention, and it's social determinants of health, and trying to come up with studies to evaluate how intervening can help patients remain compliant and have better outcomes. And Scott Ramsey is leading that initiative. So maybe Dr. Van Veldhuizen, I don't know if he knows more about it. It's still kind of early stages, but I think the GU committee should pay attention to that initiative.
So I'm leading in that clinical trials planning meeting. I'm leading the interventions group. So I will be able to report back to all of you on that. And there's lots of good stuff there, including the data on health-related social risks.
Well, I'm glad then Rick will bring up our question, but anyway, what I was going to say is that similar to Evan, our institution had the exact same experience. And that's why I think a position statement maybe, or something of that kind would help. And maybe it can come out of the CTPM to sort of, we can all show our IRBs that, you know what, this is what was covered and agreed upon.
Thank you for that great discussion. So Neeraj unfortunately couldn't be here, but fortunately, I guess there's not a whole lot to update on 1216. I think many of you have seen the primary publication. And thanks to everyone in the room who participated. I know it was a study that took a lot of us to do a lot of work. So there are still samples being processed for correlative science. There are still analyses going on. Some of the CTC work I think will be very interesting, and as we discussed this morning in our Off the Books meeting, it could help inform the design of a next generation metastatic hormone sensitive trial. So that's all I'll say about 1216, unless anyone has questions that I don't know if I can answer because I'm not Neeraj.
Any questions? Getting back to Neeraj.
Yeah, you can also email at any time and we can discuss. All right, so Heather is online. So Heather, we will be able to hear you, but we won't be able to see you. And please just let me know when to advance the slide.
Of course, yeah, thanks everyone. I'm sorry I can't be there. I've had sick child and disintegrating house, and so I just can't travel. So, but thanks for your attention. So I'll try to be efficient. This is SWOG 2210. So we've talked about this study and it really has evolved with really valuable feedback from this group. neoadjuvant carboplatin for localized high and very high risk prostate cancer with germline BRCA1 and 2. And I'll just, in following Brian, Dr. Chapin's lead, this study was also championed very early on, I think even when I was a brand new faculty by Dr. Vogelzang. So I really think that, it was partly his enthusiasm for this that gave us the sort of stamina to continue with it. So thanks to his legacy. Next slide, please. All right, so really quickly, by way of background, patients with localized high-risk prostate cancer have a 50% chance of disease progression after a radical prostatectomy. We know that germline BRCA1 and 2 mutation carriers with localized prostate cancer treated with curative intent have poorer outcomes compared to their counterparts who do not carry BRCA1 and 2. Neoadjuvant systemic therapy, as we all know, is not currently standard of care for prostate cancer, but next generation AR targeting agents are being explored and in the phase 3 setting as well. BRCA1 and 2 mutations confer sensitivity to DNA damaging agents, including platinum chemotherapy and PARP inhibitors. There's a lot more kind of press on the PARP inhibitors these days, but carboplatin, as the Medocs know, is very well tolerated, widely available, and 50% less expensive than PARP inhibitors, or 50 times less expensive, not 50%, 50 times. Neoadjuvant systemic therapy is standard of care for other BRCA1 and 2 mutation-associated cancers, for example, breast, ovarian, and pancreas. Next slide, please. So this is SWOG 2210, and the hypothesis is that 12 weeks of neoadjuvant carboplatin chemotherapy followed by radical prostatectomy for men with localized high and very high risk prostate cancer and germline BRCA mutations will result in meaningful pathologic complete response rates, facilitate deeper translational understanding, and, for example, understanding if tumors from germline carriers are more responsive to DNA damage from carboplatin and what can be learned from the molecular signatures of these tumors, and questions about monitoring for recurrence. I will say, many of you who remember the history of this study and the just many discussions that we had at this and other, in this forum, we had, a lot of evolution. We originally had 5 arms, and we had a lot of patient, Tony Crispino, and others from the patient advocacy committee group about, really having an ADT sparing arm, and then it contracted. And then the steering committee, actually, the GU steering committee advised sort of neoadjuvant carboplatin without ADT. Just, we sort of had a lot of meaningful discussions about it. And so this is where we landed based on many iterations. Next slide, please. So this is approved following the revisions on, I think, a few months back. The change study design is now single arm carboplatin, and the hypothesis is that we're aiming for a path complete response of 30% or greater. And some of the points that just to highlight, the discussions that we had at the GU steering committee was that the path CR endpoint is a strong early biological signal. There were some concerns about potential toxicity to carboplatin, but I think, we were able to address those concerns. We did address the PSMA PET issue, and really the gist of it is that they are allowed on study if there's no metastases on conventional imaging, and then the surgeon deems the PSMA areas potentially resectable. And then there was some concern about feasibility. And as you probably know, the field is evolving around germline genetic testing, but it is a reasonable concern that we will need to find these patients in order to enroll them, and they have to have germline BRCA1 and 2. And so that, depending on your institutional practice and resources locally, may potentially be a challenge. And I think this is an opportunity for young investigators like I think Dr. Sokolova is on, and Dr. Pillier and others to help kind of lead us into this new era. But I'm hopeful that there are enough clinical trial opportunities and changes in standard of practice. And actually, I don't know if Dr. Moon is on, but I think Dr. Harstark is, that Kaiser also has a really innovative new way to deliver germline testing. So I think we can leverage some of those opportunities. And then follow-up phase 3 opportunities might include, endpoints that include biochemical for progression-free survival or metastasis-free survival. We can get, I think we can take it one step at a time. Right now, it's just getting the trial written and open. But those were some of the concerns that we discussed at the steering committee meeting. Next slide, please. All right, so this is the current design It's again, high risk, very high risk prostate cancer with germline BRCA1 and 2. People can come in already knowing they have a mutation, or they can get a mutation or germline testing sort of at the time they get their diagnosis. Average turnaround time, I think, really varies, but could be 2 to 8 weeks, and typically could be as fast as 4 weeks if there is a workflow in place. And again, it's carboplatin at AUC5 for every 3 weeks for 4 doses. And the end, thank you very much to Kathy and Melissa and Sam for helping with the stats. 22 to 44 patients. We'll do radical prostatectomy with bilateral pelvic lymph node dissection. And again, the primary endpoint is path-CR. And the secondary endpoints are biochemical progression-free survival, rates of salvage therapy, time to metastasis, and overall survival. Next slide, please. Okay, we don't need to go through all of these. Essentially, the key eligibility, very high risk disease, and then we will allow prior ADT. It's not part of the study, but if they have received ADT, they may still enter the study, and we'll use that as we'll take that into account in the analysis. And I already mentioned the PSMA considerations and the fact that patients can come in knowing they have a BRCA mutation. My hope is that with more cascade testing and awareness, that men may begin to get more testing and know before or at the time of their diagnosis that they may have a germline mutation. Okay, next slide, please. And feel free to stop me. I'm talking kind of fast, but I'm trying to stay on time. Okay, statistical considerations. This is a 2-stage design. Think again to our stats team, superstar stats team. Okay, path response probability of 30% or greater would be of interest in this patient population, and further testing would not be pursued if the response probability is 5% or lower. And this is taken actually from the meta-analysis from Jacob Burchuk and Mary Ellen Taplin on the many neoadjuvant studies where they did look at DNA repair mutation carriers, and they found a 26% response rate. So here we're aiming higher than that, because we're saying, in order to justify something that is kind of being pursued, the AR targeting and the neoadjuvant setting, we want to aim even higher than that. And I think based on the breast cancer experience, it could be even higher than that. So I think it's okay to aim high. So 20 patients will be eligible to receive some treatment. And then if 12 or more responses out of 40, and then if 1 or more responds, then we'll go on to 40. And then if 12 or more of the 40 respond, then that would warrant further evaluation. And with the 10% eligibility, we're aiming, total sample size maybe up to 44. Next slide, please. Great. And Ryan, I'm just looking at the chat here. Ryan Kopp is saying that the VA also has a national contract for germline testing with prevention genetics. So that's really great. I think hopefully more of these opportunities will make this more feasible than it was even when we first started talking about this concept. Okay, so I think I've covered this. These are just the endpoints again. Happy to pause if, and I think the next slide is one that we threw in. If you go to the next one. Oh, sorry, I think there was, maybe it's not here, but I think there's an opportunity for ctDNA signature of the tumor before prostatectomy, and then following that in the follow-up for potentially for minimal residual disease. And we're happy to kind of brainstorm more with folks on that. But that's something I've been talking to Dr. Dorff and Goldkorn about. And then the last slide. All right, so just in summary, there's a schema there. What can you do to get ready other than thinking about this? I think is really think about your genetic testing workflow. I mentioned Kaiser has a workflow, and Dr. Kopp said there's a workflow through the VA. Talk to your genetics team about how you might find out who the carriers are and how you might expedite testing. I'm happy to brainstorm with you. Stay tuned for the final protocol. We're currently writing it. Taj has been helping me, and I think Dana will help us get through the finish line and to the stats team and all the protocol writer team people as well. So thank you so much for all your feedback along the way, for your support and getting us to where we are now. Thanks.
Great. Questions for Heather? Anna. Oh, yeah.
So it's so exciting to see this trial get this far. I might have missed it, but in the eligibility, was there a requirement for testosterone level? Like you said that you would allow prior ADT.
Yes, that's
so
right.
They could be have testosterone less than 50 or not?
That's correct. Yeah.
And are you going to cap the number of people that you allow to have had prior ADT?
I don't think so, although happy to talk after the fact about that. I think this is going to be a difficult patient population to recruit to. It's a small subset, and I think we want to be inclusive. And I don't know what the composition of the ADT versus not is. I mean, I think there may be some patients who feel more comfortable with it on, and other patients, as Tony, and the patient advocates really, other patients who really would be reluctant. It's difficult to sort of control that. I guess we could try to stratify or, cap it, but I'm a little reluctant to do that.
So you might have a mix of people that have ADT plus carbo and people that with carbo alone.
I think the thinking is that with traditional ADT, the path CR rate should be so low that whatever we're seeing should rationally be attributable to the chemo. I mean, we went back and forth so much about including hormone therapy or not, and it's, it would be nice to have it be clean, but it's got to be, feasible. So I don't know how many surgeons tend to start ADT prior to prostatectomy, but we must have felt like it was going to be a significant barrier to accrual.
Yeah. Brian?
With the PSMA PET permissibility, is that when you talk about resectable disease, are we saying that essentially if it's node positive only, then they can go on trial still, but if it's a solitary bone site or a retroperitoneal node, or they could still go on with an RP node, and the request or requirement is that we're actually doing removal?
Maybe I'll let Dan comment on that.
I mean, we felt like if it would be N1, not M1, pelvic only nodal mets, not bone or extra pelvic mets by PSMA, so completely resectable.
With the intent of doing, like if it's a perihilar, retroperitoneal node, you'd want that removed.
No. So if by PSMA, it had to be N1, not M1.
Okay, so maybe just say PN1 and not,
right.
or CN1 by PSMA
Yes,
PET.
CN1, right, not CM1.
And it's not required, that's just permissible. So I would choose not to do it because I don't want to deal with this problem.
Right. That's right, exactly.
And it looks like the ctDNA slide did make it in. So this is a collaborator from TGen, Dr. Murtaza, who has this TARDIS protocol where, ctDNA in the low volume metastatic state can be very hard to find because of limited sensitivity across the board. But if you start out with the patient's tumor and identify specific abnormalities from the tumor, what he's shown, and the publication is listed here, is that you have a significant increase in sensitivity. So he's already done this in breast cancer and shown an ability to differentiate those who recur from those who don't. So I thought it would be interesting to consider adding this. We do have some philanthropy funds to help support this kind of an assay, but let's talk about it at one of our Friday calls if people have other ideas as well.
Does this have to be a pure adenocarcinoma? Because the cribiforms as well as the ductals may actually have a higher rate of BRCA expression. Will those be included in this or not?
Yes.
Otherwise, meet eligibility, I would say yes, absolutely.
Great. If no other questions, we'll move
these are
on.
extra slides. We can skip through these.
Okay, perfect.
Thanks
so much, Heather. Great work, and great work to the whole team. So we'll move on to Paul. Okay, Paul's gone. So Paul and Anna have a great concept that's been through the TF at least once, twice actually, I guess now, right? Yeah, twice. Good feedback. So why don't you give us an update?
Just,
yeah.
Okay.
Green button.
Is there a way to use a pointer?
Oh, pointer.
Oh, there we go. It's old fashioned. Oh, gosh. Okay, thank you very much. It's great to see everybody. And yes, wanted to give you an update on this phase 3 concept, a study of cabazitaxel with or without carboplatin in patients with metastatic castrate-resistant prostate cancer stratified by the aggressive variant signature. On behalf of the co-PIs and the study statistician, Kathy, I wanted to review some things. So this concept is one that this group knows well. We've been interested in, as has other groups, in AR and different prostate cancers, and have identified a subset that we've termed aggressive variant prostate cancers. And the interesting thing about this subset is while one of the definitions was small cell, we appreciated that there are a number of cases with adenocarcinoma histology, but they actually behave clinically like the small cell subset, including phenotypes like a lytic disease, low PSA per disease volume, and in particular, platinum sensitivity. So in an initiative largely spearheaded by Dr. Anna Aparicio, she identified a molecular signature we've called the AVPC-MS that's characterized by a loss of 2 out of 3 tumor suppressors, shown here in the lower left of P53, RB, and PTEN. So we've done a number of studies. The largest we did was a randomized phase 2 where we took patients at that time, just sort of all comers, and we randomized them between cabazitaxel at 25 milligrams per meter squared versus cabazitaxel 25 milligrams per meter squared plus carbo AUC of 4. And then while there was a benefit in a post-hoc analysis shown by the red arrow there, we found that the benefit in terms of progression-free survival was superior if patients harbored this aggressive variant molecular signature. So we wanted to extend this work to a larger phase 3 with the hypothesis that the addition of carboplatin to cabazitaxel will significantly improve radiographic progression-free survival compared to cabazitaxel alone in men who possess the signature, but not in those who are negative. So I'm going to spend just a few minutes highlighting perhaps the comments that we got over a period of many months, not only from this group, but the SWOG prostate group, as well as Dan mentioned, 2 presentations to the NCI prostate task force. And I would summarize by saying it was a very constructive process, and we really took to heart and made a number of significant changes that I'll emphasize here. And we're hopeful that the changes that we still didn't feel comfortable making represent reasonable differences of opinion, but not necessarily a major roadblock. So one of them was to take small cell patients out. I think there was a sentiment that small cell would likely be treated up front with etoposide cisplatin or other regimens. So we did take those out of the eligibility. We changed the number of prior systemic therapies from less than 2 to 3 to try to enhance eligibility. There's been a lot of discussion about biopsies that we hope to use to determine the signature prior to enrollment on the study. And we've looked at, anything from a biopsy immediately before to even material that was 3 years prior, even in the castrate-sensitive disease state. But we ultimately feel that 12 months is probably the best because, again, what we want to avoid is patients who have older biopsies that may not have had the signature, but then under the influence of therapy, develop the aggressive variant phenotype, and we would miss those if we didn't have a more recent biopsy. So we prefer the 12 months. We've stratified by prior docetaxel use and also the AVPC molecular signature. And we are going to permit local determination of the signature from CLIA-certified DNA tumor analysis. That was another idea that we took to try to again, enhance a speedy enrollment. There was a lot of discussion about DDR. We certainly know that that can play a role in platinum sensitivity, but all the groups, including the task force, were comfortable with the notion that we're going to look at that data, but in the post-hoc setting, that we wouldn't use it for prospective stratification. Another key point was cabazitaxel and the idea that many institutions are using as their standard 20 milligrams per meter squared. So we thought that was very reasonable to allow institutions to select that dose based on their preference. Another point was whether or not to push the carboplatin dose to AUC 5. And again, we've gone back and forth about that, but really because our phase 2 data used an AUC of 4, and we have to balance that consideration against other thoughts about toxicity. We felt comfortable and would like to keep the AUC at 4. There was agreement about the RPFS endpoint and most of our endpoints. A more recent discussion took place again about how to incorporate novel molecular imaging. So a little bit like what's been said with the earlier concepts, we would allow PET PSMAs, for example, but really just to use the CT portion for RECIST and still require a bone scan, but we were reluctant to change our definition of progression since those have not been harmonized yet for the new scans. I would then say that we have this as our statistics, which Kathy has been instrumental looking at an improvement in RPFS from 5 months to 10 months if you have the signature. There was a discussion about, we have a step-down approach where we're going to initially look in the AVPC positive group, and if we do see a treatment effect, because that's the group we're most confident about, we would then look at the negative group. There was some suggestion to step down to the entire population, but again, we're really interested in understanding how the biology of the signature and what it implies differentiates benefit from those that have the signature and those that do not. We were suggested to cap the biomarker negative population at 70%, which made a lot of sense, and we did that. So here's a quick sort of summary in a table format. I'll just go through this quickly, as you can hopefully see. I know it's a bit busy. We excluded the small cell. We felt it was a good idea to be flexible on the Kabazi dose, but we're hoping to keep the AUC of 4. We will integrate the molecular imaging, but not for the RPFS endpoint. We still feel that the eligibility biopsy window is best kept at 12 months. The signature can be determined locally, but ultimately when we do the stats analysis, we'll use a central determination because all these samples we're going to have sent slides to MD Anderson to have the signature determined by IHC, though we again will allow CLIA certified MGS reports to be used for the initial randomization. I didn't cover this, but there was a discussion about only including homozygous deletions of P53, P10, and RB, but again, we didn't do that for the phase 2, and I think there's some, again, reasonable challenges about understanding the technical ability to distinguish heterozygous versus homozygous in situations of aneuploidy, so we didn't want to do that. We'll be looking at DDR. We'll be testing the effect in the AVCP positive and then negative, and the last one was toxicity concerns about patient dropout. And we didn't think that was going to be necessary because, patients drop out for different reasons. And I know it's really not fair to look across studies, but I think there's a number in the room now that have probably used CAB-CARB. And this is an example of percentages of patients that stop due to toxicity, looking at different trials that you can see there. In my view, I think the incorporation of growth factor has really helped administer these combinations safely. And again, in our study, actually more cycles of CAB-CARB were given compared to cabazitaxel because it actually was working a little bit better. So I hope that those of you who have not used it would not be sort of worried about giving it a try. And of course, we would love to hear what the patient advocates say. So that's a quick summary. Again, we hope this will be a trial that really helps us define a molecular signature for men with AR indifferent lethal prostate cancer and fill important gaps in the development of a biological marker-driven treatment paradigm. So we hope to take this to the SWOG Executive Committee. And again, appreciate your time and any additional thoughts, questions, or concerns. Thank you.
Questions?
So I think it's an important trial, and I use this combination for patients who are, it's RPC that have very aggressive disease or, by different criteria and gestalt, and also, the patients who may or may not be having the neuroendocrine transformation. But I think there's going to be, I guess my question is the intention of this trial for us to enroll all CRPC patients who are going to get cabazitaxel, or for, there's going to be some selection bias that we're going to be enrolling the sickest patients into this trial, meaning that patients that we would like them to get carboplatin somehow. And then, or that we think they might benefit from carboplatin and therefore they're going to be offered the study. So you could look at it this way, is there may be some dropout that, well, if I think the patient is sick enough that they should get the combo, then I wouldn't randomize the patient because I feel strongly he should get carbo if it's a neuroendocrine phenotype type of patient. So is the intention, I mean, I guess the intention looking at this is to enroll all CRPC patients that are going to get cabazitaxel, period, without much thinking, right? Or is the intention to focus on these really bad neuroendocrine phenotype cases, or the other way around?
I understand. I'll state what I think, and Anna might have some thoughts. You know, I think for us, really, I would view it more as sort of the all-comers concept, that what we're really trying to attest is the ability of the marker to predict sort of aggressive biology. And, you know, there's some thoughts that of applying some of these concepts even in the hormone naive state. I appreciate what you're saying about the ability to sort of guess who might need carboplatin, but I think the fact that the marker analysis is required for the trial would hopefully sort of control for that. Even I think in some of the early data from Brian's M1 data, again, there's a subset of patients that have this de novo. So, but Anna, please, yeah, if you wanted to make a comment.
Just to make the point that Paul's trial was actually positive for the overall population. So the radiographic progression-free survival improved with the combination in the overall population. And so based on a post hoc analysis, we generated the hypothesis that it's the people that have this molecular signature that are more likely to benefit, but that remains to be tested. So I would think of it as an all-comers.
Yeah.
Terrific. Hi.
Nice to see you.
Very, very enthusiastic about this trial. I've used this regimen
Good.
off-label,
Yeah.
and I've really been impressed with the lack of toxicity.
Oh, good.
And I think this is really going to be a very, very interesting study. So my question is about the number of prior treatments. So you're saying 3 or fewer prior treatments for metastatic disease. So I would actually try to do that by class, because often in the community, you'll find somebody who received abiraterone, enzalutamide. You know the enzalutamide is not going to work because they're doing that for various reasons.
I see your point.
So that's, I think, one thing that you may want to
I got you. So if they got Abby and Enza, that's sort of
Right.
one.
Right.
Yeah,
So
follow.
I would do by classes,
Yeah,
you know, rather than doing it by
just number.
number of treatments. That's the first
I
thing.
see
Second
that.
thing is the issue about lutetium PSMA. So 3 prior treatments, that's the group that will be getting LU-177. You may actually want to either consider stratifying or excluding, because as we know, one of the problems with carboplatin is thrombocytopenia.
Yeah.
And with some of the isotopes, we really don't know what the effect of giving an isotope is and then giving chemotherapy after that. So we don't want to, you know, lose on a toxicity issue in this particular trial. So either stratify or exclude.
That's a great point. You know, I have to confess, we've been working on this for some time, and the concept sort of preceded the explosion of the Pluvicto. So those are very good points.
Hi, Laura Esfeller, kidney cancer patient advocate. I just wanted to know, because toxicity was such an issue, is there any allowance in the study for either a treatment break, dose reduction, anything of that nature?
Yes,
Okay.
I think, and I think you hit the nail on the head. You know, again, we found, I think if you build in the proper dose reductions, that really helps as well. And it's not that we had that many actually on our trial, but that certainly helped some patients get over. If I recall, there was some limit on the treatment break, perhaps up to 4 weeks, but I think you raise a good point that with the careful treatment that I know everybody would give, we can usually mitigate these toxicities. Has been my impression.
Dr. Gordon, a question for clarification on the stratification factor for prior docetaxel. I assume that's prior docetaxel in the CRPC setting, because otherwise the package insert for cabazitaxel indicates you have to have had docetaxel.
We were asked we initially had it in the castrate resistant, but we were asked, and I didn't make it clear there, to allow it to be in either disease state. How does that sound to you?
I guess my concern is if somebody has no prior docetaxel exposure, will cabazitaxel be supplied? Because otherwise, I'm afraid some insurances may not cover it.
I understand. We've had reasonable success in getting that, but yeah, we had a long discussion this morning about the ability to sort of get support, for this, including from Sanofi, which we're still working on. But I see your point. Yeah, I got to think about that.
If I can make a great concept, by the way, this is great. And my only comment to follow that prior comments from Dr. Petrolak has to do with PARP inhibitors. Are you thinking on allowing those as part of the,
Yeah. That's a great point too. Anna, do you have any thoughts on that? Because again, from your own trials, Anna has some sort of carbo followed by PARP trials in terms of, cross biology, cross resistance. Any thoughts? That's a great point.
Yeah, I mean, so I think we should probably include them. And then, sort of keep an eye on it in a sense. I don't think we can formally test it, but I wouldn't exclude people that have had prior PARP. I think, we sort of, it's all about compromises, right? I'm not really excited about the prior docetaxel. Obviously, you have the issue of the insurance approval, but prior docetaxel in the castrate-resistant setting, I think, we saw in our study that it sets you up for a little bit of failure. But I would keep the PARP inhibitor.
Yeah, okay. Oh, yeah, very good suggestion still.
Okay, any other comments? Great feedback.
Thank you. Yeah,
Yeah,
thanks
really,
very much.
really
Really
good.
appreciate it.
The task
Thank you,
force
Tom.
missed all that, but that's okay. Okay, yeah, great. So, Evan Hughes, laughing because he's on the task force, looking at me online here. So we're gonna move on to the champion trials. So there's a litany of them, and most of the people are online. So we're just gonna turn it over just online. I guess, Evan, you're first. Just tell us when you want to advance the slide, okay?
Yeah, sounds good. Thanks so much. This is the EA 8191 Indicate trial. So this is for patients who have undergone radical prostatectomy and now have biochemical recurrence and are considering salvage radiation therapy. So there's really two questions being asked here, and it's based on next generation PET imaging. It can be PET imaging of your choice, although most people are doing PSMA PET. And the questions are that if you don't have any extrapelvic metastases found on PET, the question is whether 6 months of ADT plus apalutamide adds benefit in regards to PFS versus just 6 months of ADT. And if you do have extrapelvic metastases, to ask the question as to whether metastasis-directed therapy with 6 months of ADT and apalutamide is better than 6 months of ADT and apalutamide. And in regards to PFS, as you can see, a lot more sites are open now. 65 sites, 270 pending, 54 patients are enrolled, and this is Neha Vapawala's study. I think this trial is starting to accrue pretty well now. Next slide, please. So there have been some amendments, and this has been very, very helpful. First off, they've really expanded the permission for different radio tracers. So it can be PYL, it can be gallium-68, PSMA, et cetera, et cetera. So the other thing is they've loosened the criteria for androgen deprivation therapy. Can be an LHRH agonist, an antagonist, can be oral, relugulix, to allow flexibility. They've expanded the timelines for baseline imaging. So for conventional imaging, you could get that within 26 weeks prior to step 0 registration. And for PSMA PET, or for any next generation PET, it can be within 16 weeks. So you can actually get the PET beforehand and then go on afterwards. And also, they're not mandating that the radiologist be trained. The site does have to have the scanner registered, but the radiologists don't have to be trained. Now, this is one thing that's caused some questions in regards to recurrence. So the key thing is that if you recur within 12 months from radical prostatectomy, the minimum PSA level is less than 0.2. And if you recur after that 12 months, then it has to be 0.5 to be eligible. Some of the challenges were in interpretation because some people were recurring with very low level PSAs within 12 months, but they weren't quite to 0.2. So there was some confusion. Those patients are eligible, and now this is clarified with this additional amendment that's coming. Next slide. I think there's one more slide in there, right? Can you back up? Or maybe it just got dropped out. Oh, well, it got dropped out, but I'll just ask. Neha had one question for the group, and it was about bicalutamide. Bicalutamide is not excluded, but they have nothing in the protocol about how long. And she's wondering whether the groups think that it should be limited to 3 or 4 weeks, or whether it just doesn't matter. Most of us aren't using bicalutamide in this setting. I mean, we don't have to worry about a testosterone flare for this rather early stage setting, but that was her key question that she wanted to ask the members of SWOG. That's it.
So the question is who uses it or how long they use it?
No, and right now the protocol is agnostic. So if you want to use bicalutamide, you could have used bicalutamide for a long time and then enroll the patient. So there's no time limit on it. Again, most of us aren't using it, but then they haven't encountered issues, but they're just concerned that if somebody does use bicalutamide, should we be limiting the time frame? Like a lot of protocols say up to 4 weeks or something like that.
You're specifically saying like in arm A on the slide here?
I'm sorry, your question?
Would it be in arm A? I mean, you're talking about a run-in of bicalutamide.
Yeah,
during
run in a
standard
bicalutamide
established-
for any arm.
For any arm.
Yeah. And she's wondering whether people feel strongly that there ought to be time limits on that.
Comments?
Just raise your hand if you feel strongly there should be a time limit on bicalutamide. Going once?
No hands, Evan.
Okay.
Okay,
0.
great. I'll give her that feedback. Thanks, everyone.
I'm sorry about the slide. I really,
I think they're advancing on their own.
yeah.
Paul? Yeah, yes. Okay, perfect.
This is pretty quick, you guys. So this is the Charted 2 trial. And the title there, Cabazitaxel with or without abiraterone. Charted 2, and you go to the next. I just want to remind people of the study because it's actually closed to new patient entry, but you can see they took castrate-resistant patients after prior docetaxel in the hormone-naive setting, and then they randomized between abiraterone versus abiraterone plus cabazitaxel with the endpoints described there, PFS, OS. And they have some exploratory endpoints with ARV7 status and incorporation of sodium PET fluoride along the lines of what Glenn Liu has been studying in ECOG. And really the update, if you go to the next slide, is that we, I think, represented well, appreciated everybody's support, but they really, as of just a couple days ago, Christos told me they won't have any data until October of 2023, and he wanted me to kind of ask people just to catch up on your rhesus measurements and try to get your data up to date to help them out. So thanks for everybody's support.
Great, thank you. Next up is Eradicate, which is the adjuvant post-prostatectomy for high risk but node negative prostate cancer patients. They have to have a Decipher score greater than 0.6 to get in. This study has been slow to accrue, so I'd like to encourage sites who maybe haven't opened this trial to think about opening it. Patients get randomized to a year of standard ADT for 12 months versus ADT and darolutamide. So the big updates, remember that unfavorable intermediate risk could qualify if they have a CAPRA score. I think it's a relatively modest CAPRA score to get in. I'm blanking on the number, but it's easy to calculate the CAPRA score, so I would encourage you to do it on your intermediate risk patients just to see if they qualify. Decipher testing is paid for by the study, so that might be a motivation. And then you can do remote consenting as long as your local SOP allows for it. And radiation is allowed if that's something you would want to offer these patients. You just have to declare your intent before they're randomized. And then I've listed some of the study contacts, so thank you.
Anyway, come on.
Just quickly, EA 8171, this is the multi-parametric MRI before prostatectomy study. Just to remind some people about so Claire Timpani is leading the study. We're doing with ECOG Akron. So the hypothesis, in case some people weren't aware of it, was the PIRADS. Obviously it's a lot of variation between sites. So to detect aggressive or clinically significant disease, they're also looking at staging for MRI and to improve selection of patients for surgery. Primary endpoints is estimating diagnostic performance of PIRADS and also to develop a risk prediction model. And secondary endpoints are more on the PIRAD score, but some of the tertiary endpoints are pretty cool with AI and normalization of MRI. The schema is very easy to enroll studies, essentially just having to get your scanner qualified for the study. I think that's what takes most of the effort. And at the bottom here, so their total accrual target was 852 patients. So far, there's 566. There's about 300 patients to go. There was a pretty significant decline recently. So they wanted me to mention that to everybody that it's still open, enrolling. They just want this final push to get the MRIs done in a fashion that's perfect. Thanks.
Great. Okay, 007, I think, David, are you online?
Yeah, yeah, I am, thanks.
Perfect.
So this is a study to see if PARP inhibitors improve sensitization to radiotherapy. It's not a biomarker-driven therapy of PARP inhibitor, and it's looking at niraparib with combination radiotherapy and androgen deprivation. There's an initial phase 1 portion, and we are still in that phase 1 portion. There's because of there's sort of a prolonged monitoring period looking at safety, and so this portion has gone kind of more slowly. We are currently at dose level 3, and there haven't been any DLTs yet. Hopefully in the next couple months we can progress on out of phase 1 to the phase 2. If you can advance the next slide. So this is the phase 2 portion. The eligibility open up for Gleason. Right now it's really, I think it's grade group 5 currently in phase 1, but in phase 2 it opens up to Gleason 7 and higher with some other metrics based on PSA and T stage. And then it becomes a randomized study of ADT radiotherapy or ADT radiotherapy and niraparib, with the primary objective being PSA remaining less than 0.1 at the end of ADT. So still in early stages.
Great, thanks, David. This is GU008. Ron Chen is the overall PI from NRG on this. And just to remind people of this study. It's not going.
The slides aren't advancing.
Yeah, great, thanks. So this is the schema, and this is, again, node-positive patients after prostatectomy with a detectable PSA. So, and with a negative PET. So PET is required to be negative, detectable PSA with node-positive disease. They're randomized to either, and RTs in both arms, of course, it's an NRG trial, and either just standard androgen ablation versus intensified with apalutamide. Next is the recent protocol changes. They did have to, of course, add in PSMA PET. They are allowing for hypofrac and proton therapy, and patients can have ADT up to 180 days. The oral agent is pending approval. Next, standard, it's a MFS endpoint with the listed secondary objectives, quality of life, and OS, of course. And then the last is just their status. So the target accrual is almost 600 patients. They are over 100. They're doing okay. The last couple of months have been very good. SWOG, we do have some SWOG sites that are activated on this. I think that we were kind of slow to come on, and of course, nationally, we're having some issues with activating sites, but they're doing okay. So next.
So the first GU009 slide dropped out. I apologize.
That's okay. I'll just describe it. So GU009 is the high-risk study at NRG. It's there's an escalation and de-escalation randomization. It's high risk clinically, and then Decipher score high or low. So the low Decipher score, high clinical, will be 24 months versus 12 months ADT with standard radiation. The escalation arm is 24 months ADT with or without apalutamide. And it is accruing like gangbusters, and encourage everyone to open it.
I'm so sorry about that. I have a lot of issues with the slides. The last one, I don't know if Dr. Coley's on the line. We're not able to see all the participants. All right.
So we're going to have the last 5 minutes. We have 5 minutes? Yeah. So last 5 minutes, we wanted to introduce a couple of concepts. So, and get some feedback and just put it out there. We discussed many of them this morning at our Off the Books meeting. While Tanya's getting the slides up, I want to introduce Jack Andrews. Jack can come up. Jack is a fellow at MD Anderson, and he's being mentored by Brian Chapin. I think Jack is like a prime example of a young investigator who wants to make clinical trials his career. So has a great concept to introduce to us once we get your slides up on a true adjuvant after prostatectomy node positive trial. So.
Thank you, everybody. Title of the trial that Dr. Chapin and I have worked on is Adjuvant Lutetium-177 PSMA for lymph node positive prostate cancer after radical prostatectomy, a phase 2 clinical trial. As we all know, the FDA has now approved Lutetium-177 PSMA in the mCRPC setting, and there's a trend to push theranostic PSMA into earlier disease settings. Our hypothesis is that adjuvant Lutetium-177 PSMA in PN1 prostate cancer patients will act as a scavenger for micrometastatic disease and deliver radiation to unseen disease and lead to an improvement in BCR and other outcomes. Our design is that we would have patients undergo radical prostatectomy and pelvic lymph node dissection, and those with 1 through 5 positive nodes and an undetectable PSA at 3 months' time would be identified and eligible for enrollment. They'd be randomized into an observation cohort or a treatment cohort. The treatment cohort would be 2 cycles of Lutetium-177 PSMA separated by 6 to 8 weeks. They'd get 5 gigabecquerels of lutetium per cycle, then they'd go on to PSA surveillance. The primary endpoint we chose for this trial was biochemical progression-free survival at 3 years. Secondary endpoint would be to look at radiographic progression at the time of biochemical progression. Working with biostatistician, the estimated 3-year biochemical recurrence-free survival rate based on historical observational cohorts would be about 50%. Looking at an absolute estimated improvement over observation of 20 to 30% and using a power of 0.8 with a randomization of 1 to 2 favoring the treatment cohort, we'd need between 46 and 16 events. Erring towards the 20% absolute improvement, we'd say we need approximately 110 patients accrued for this trial. I'm happy to take any comments, questions, or thoughts. Thank you.
Comments? Feedback? Great.
Who would be funding the lutetium PSMA?
Pardon me?
Who would be funding the lutetium PSMA?
That's a great question. I don't think we have the answer to that one yet.
I think this would be a great trial to take to a patient advocate to see and bring them data about the risk of xerostomia with 2 cycles of PSMA lutetium. If they would have xerostomia for many years after a trial like this, I'd be concerned about that. But again, a patient advocate would help.
Great point.
Yeah, similar concern. I just attended a session at Mayo from the myeloid group. They were presenting some data on CHIP mutations, and these patients are at high risk for transformation after getting Lutathera in neuroendocrine tumors. And our GI group is now seeing a certain progression or uptick of myeloid malignancy after Lutathera treatment. So the risk for this drug may be higher than immunotherapy or other forms of therapy. So to give a patient who may not recur, we have to balance that risk. Maybe we can think of a design where there is PSA recurrence already and PSMA PET scan is negative. So then you can justify the risk of giving the drug to a patient who is technically PSMA negative, and then following for radiological progression or metastases-free survival, something like that.
Those are really good points. You know, we had that in mind with this patient population that has a much longer life expectancy than those in the MCRPC setting. In the VISION trial, for example, these patients are getting 7.4 gigabecquerels for 4 to 6 cycles, and that's why we tempered to 2 cycles at 5 gigabecquerels to give them a much lower dose. But certainly something we need to find out more about with exposure to normal organs. And then, you know, these are things that we're hoping to explore further to understand better as we move it through the castration sensitive and then earlier settings. And we have a neoadjuvant trial that we're about to start accruing for that hopefully will give us more information in those settings as well.
So I assume you're following these patients for life, correct?
Yeah, so I think we would have to follow them for life, but for the primary endpoint, we wanted to set that at 3 years to get the data and go from there.
If you remember from 9921, we didn't start seeing leukemia until year 9. So this is something that's really going to be important for long-term follow-up.
I agree. And one other point I wanted to make is that while these patients don't have radiographic disease, their risk of having recurrence at 5 years is 80%. So these are extremely high-risk patients of having recurrence. And so while they don't have disease at the time of treatment, they're extremely highly likely to develop disease down the road.
Yeah, this is Evan. I just, I like the concept. I think it's great. I just have a quick question whether this is the right agent to use in this situation. I mean, I'm far from a nuclear medicine doctor. Maybe there's a nuclear medicine doc in the room that can comment. But, you know, I've heard from other nukes doctors that beta emitters are not ideal for an adjuvant situation, that actually you need a tumor mass there for this to really work ideally, and maybe an alpha emitter would be more ideal for an adjuvant situation otherwise, you know. So anyhow, I would just you know, I'd love it if there was someone in nuclear medicine that could comment on that, because I've heard it from some of our top nukes docs in the field that have made that comment.
So we appreciate all the feedback. We'll be able to workshop this some more. It's a very early presentation. We're over time. So maybe last question, Jorge, you've been waiting patiently. And
no, I was just making the same comment that Evan just made. The likelihood of you having a PSMA negative patient in the CRPC space, if you look at VISION, is between 10 to 16%, right? So it would be hard for me to believe that if you have a PSMA negative study, how you can reconcile giving someone lutetium in that context, unless biologically there is some data that we may not be aware of for those patients.
Good point. Thank you.
So it sounds like we'll need to come back with some of the neoadjuvant data. And there was one other concept. I'm just going to put it up. We don't have time to actually discuss it, but just as a teaser to entice you to join the Friday prostate calls. Dr. Sokolova is developing a concept for metastatic hormone-sensitive prostate cancer, answering what I think is the #1 question, ADT-ABI versus ADT-ABI plus DOSI. There's a simple design. This is a very easy to accrue trial, endpoint rPFS. Discussion this morning about possibly specifying docetaxel as first CRPC drug. There's a more complicated design which could build off of studies like 1014 and the data from 1216, looking at PSA nadir, and maybe going to add the docetaxel for people with inadequate nadirs, maybe at an earlier time point than 6 months. Maybe if we look at 1216 data for that, maybe an innovative biomarker. So if you're interested in workshopping this and Dr. Andrews' concept, please join us on the Friday prostate calls. And I'm so sorry we went over, but we're all done.
Great, thanks.
So welcome everyone. We're going to run another experiment this evening. So we have special guests today who are going to be presenting remotely. And we're going to see if the share screen option works. Oh, the slides aren't even loaded. So let's go ahead and Gopa, are you on?
I am, yes. Can you hear me?
I can hear you. So we would like to have Gopa be able to share his screen.
Let's see, I think I can actually do that. Let me see. Are you able to see my screen?
You can see it on one computer. Are you in presenter mode? We just lost you. There we go. Great.
Does this work? Yeah.
It works.
Perfect. Okay. Thank you. So thank you, David, so much for the opportunity to present a quick update on the correlative analyses for the SWOG 1314 study. So I'll be very brief about this. This was a randomized phase 2 trial of the Coxin with neoadjuvant chemotherapy for localized muscle invasive bladder cancer. And you can see here that Dr. Flagg was the main PI for this study, and of course had help from many other members of SWOG. So the study is completed, and the primary objective for the study, you can see here, were to characterize the relationship of dose-dense MVAC and GC-specific Coxin scores in terms of the PT0 rate at cystectomy in patients who are treated with neoadjuvant chemotherapy. And this is going to be done in a couple of different ways. One was to assess whether the Coxin score was prognostic of PT0 rate for less than or equal to PT1 in this patient population, and then also to look at the correlation between GC and dose-dense MVAC Coxin scores. And I'm sorry, is this actually in notes mode? I can try to change it if it is.
Looks like it is, yeah. We're seeing the next slide. Maybe
Okay.
go up to the top and say display settings.
That's what I'm trying to do here usually.
Yeah, it's right to the right of that one, right in the middle, where it says display settings.
I do not see that on mine, but let me see if I can.
It's okay.
Yeah, I might just move on in the interest of time, if that's all right. Yeah. So there were translational aims for this study, and the primary analysis was actually, you can see, was the Coxin analysis, but there were multiple secondary analyses, including specifically looking at DNA, microRNA, as well as CTCs and SNP analyses that were performed from correlative samples that were taken in the study. And so I'm just going to focus primarily on the DNA-based analysis. So this was an analysis that was done. It was funded through a BIQ SFP mechanism. And the idea was to look at the association of deleterious DNA damage response, or DDR gene alterations, with response to cisplatin-based neoadjuvant chemotherapy in MIBC in these patients. So the primary objective was to determine whether the deleterious alterations within a panel of 9 DDR genes was associated with pathologic downstaging to less than PT2 after cisplatin-based neoadjuvant chemotherapy. And then there were a couple of secondary objectives as well, including determining whether the deleterious DDR gene alterations were associated with improved overall survival and metastasis-free survival, and also determining if there were any differential response rates as well by mutation or by treatment arm. And so a brief background for this, we hypothesized the deleterious DDR gene alterations are associated with pathologic downstaging after neoadjuvant chemotherapy. There have been a couple of retrospective analyses now that have been performed from Dana-Farber, MSK, Fox Chase, and others that have shown that there is a correlation between the presence of deleterious DDR gene alterations and downstaging. And we wanted to see whether we could see a similar correlation using the SWOG 1314 specimens. So we looked at pre-treatment specimens from S1314 to try to validate whether DDR alterations could predict for pathologic downstaging in these patients. So in terms of the specimen details, we had pre-treatment tumor as well as germline DNA for this analysis. We had 500 nanograms of tumor and 250 of germline. And actually, this is sort of a going through the breakdown of specimens. So initially we started with 237 patients who had actually been enrolled onto the SWOG study. And then from here, we went down to about 216 who were eligible for the actual study. 199 specimens were collected from these patients. 17 patients had inadequate tissue for DNA extraction. And then from these 199, there were 184 patient samples that had adequate tumor tissue for the next generation sequencing assay. So we use the MSK impact assay, which is an exon capture sequencing assay. It sequences all exons and select introns from 506 genes that are commonly altered across cancer types. It includes the 9 DDR genes that we were interested in as well. And then ultimately, so there were 184 specimens in sort of the genomic cohort and 179 patient samples where we had clinical outcomes analyses. 5 patients were invaluable because they didn't undergo a cystectomy within the pre-defined time frame for this study. And so this is an oncoprint that basically shows all of the genes that were altered in at least 10% of sequence specimens using the N of 184. And so what's shown here, each of the individual columns represents an individual patient who underwent sequencing, and then the genes that were altered are listed on the left with the percentage of alterations as well. And so this is very similar to the urothelial TCGA in terms of the genomic profile. We saw mostly TERT promoter mutations were the most common alterations, followed by TP53, and then of course alterations within the sort of family of chromatin remodelers like KMT2D or KDM6A. We also saw alterations within individual receptor tyrosine kinase pathways such as PIK3CA. And then you can see here too, below that, ATM and ERCC2 were also altered within this cohort of tumors. Again, very reflective of sort of the alteration rates and the specific types of alterations that were seen within TCGA. And so when we then looked specifically at the 9 DDR genes that we were interested in, this oncoprint shows all of the alterations that were identified within these genes. So this could be both activating alterations that were thought to be oncogenic as well as loss of function alterations. For the purposes of this study, we felt that ERCC2 alterations, any alteration within ERCC2 was likely going to result in impairment of ERCC2 function. And so these were all included in the analysis. If we then look just at deleterious alterations, there were far fewer of these. We define these as basically any ERCC2 alteration, as well as any nonsense or truncating or splice site alteration within the other 8 DNA damage response genes. And so what we found was that, again, when we look just at deleterious alterations, it's a lower percentage, but it's also pretty similar across multiple cohorts as well in bladder cancer when we start to hone down on functional impact. And so in terms of the primary objective, when we look at the association of deleterious alterations with path downstaging, we actually saw definitely a correlation between the presence of ERCC2 alterations and downstaging to either PT0 or less than PT2. So 54% of the patients who had a complete response had an ERCC2 alteration and 62% had downstaging. And when we look at any deleterious DDR gene alteration, you can see again a correlation here. 51% of the T0 patients had, and 56% of the downstaging to less than PT2 patients had a DDR gene alteration. So, response rates were definitely higher in the ERCC2 altered as well as the deleterious DDR gene altered cohorts, and they seem to be independent of what type of regimen the patient received, GC or dose-dense MVAC. And then specifically when we look at the odds ratios for these, what we see is that ERCC2 alterations as well as deleterious DDR gene alterations were significantly associated with pathologic downstaging as well as with PT0 response. And you can see that there with the significant p-values showing that this is the case. On the right-hand side, when we look at PFS and OS, there was possibly a trend towards statistical significance with PFS and any deleterious DDR gene alteration, but it was not statistically significant. And the same was true with overall survival as well. And no other individual gene within the 9-gene panel was associated significantly with downstaging. It was just ERCC2. These are the survival curves as well. So it was a secondary objective of this analysis. When we look at the association of deleterious DDR gene alterations with survival, we can see that there was, again, numerically favoring the presence of deleterious DDR gene alteration in terms of PFS and OS, but not statistically significant. And then when we look at ERCC2 specifically, we can also see that there was not a statistically significant improvement in PFS or OS with the presence of an ERCC2 mutation. Certainly the hazard ratios are going in that direction, but probably hampered a bit by the total N that we're dealing with here. So in conclusion, ERCC2 mutations as well as deleterious DDR gene alterations did correlate with improved pathologic response in the S1314 patients who were treated with neoadjuvant cisplatin-based chemotherapy and cystectomy. Deleterious DDR gene alterations were associated with improved PFS, and these results really are in line with our retrospective analyses displaying a similar correlation between DDR gene mutations and cisplatin chemosensitivity. So this was exciting to see that there was a similar signal in this study, and there are at least 3 prospective trials that are now leveraging DDR gene alterations to identify patients who might be managed with an organ-sparing approach following cisplatin-based chemotherapy. And then just last slide here in terms of next steps, we are correlating response now with individual ERCC2 alterations and predicted nucleotide excision repair impairment. We're doing that using an in vitro proteoprobe assay in conjunction with Dr. Kent Mao at Dana-Farber. And then we're also investigating the ERCC2 and DDR gene alterations that were not associated with pathologic downstaging to see what other factors might have specifically affected or impacted sensitivity in those patients. There's been a poster now that's been presented summarizing this work at ASCO 2022 and a manuscript currently in progress. Thank you very much.
Thanks, Gopa. So Leslie talked this morning about one of Gopa's trials, one of the bladder preservation trials. Are there any questions for Gopa? Seth Lerner.
Hi, Gopa, it's Seth. This is terrific. So we're seeing, and you alluded to it, this sort of disconnect between PT0 pathologic downstaging and either PFS or OS. And what you showed us is not unique in that sense. You seem to suggest that maybe it's a function of length of follow-up, but perhaps you could just sort of share your thoughts about this potential disconnect. We had a big meeting with the FDA. There's a paper out there about pathologic downstaging and outcomes, and it's kind of messy. And just in terms of it not yet being a validated intermediate endpoint. So curious to hear your thoughts.
Yeah, no, I think that's a fantastic point, and you're right. I think the jury is still out regarding, just how good sort of pathologic downstaging or PT0 is with and as a surrogate marker for PFS and OS. I mean, certainly, I think most of the confidence we have in that, really stems more from SWOG 8710 and additional studies that are smaller that have shown a correlation, between longer survival. I do think in this situation, though, we really are talking about a biomarker in isolation, and we do need to think about other clinical factors as well that may also be playing a significant role here, in terms of sort of the size of the tumor, multifocality, et cetera. And those are sort of all being looked at and included in the eligibility criteria for some of the prospective clinical trials that are looking at sort of a bladder sparing approach, because obviously, we want to ensure that there is sort of a survival, there's not a negative impact on survival in those patients who keep their bladder. I also think, though, that it does come to in part also, the actual S1314 study, the survival data are still immature, and so we are waiting for longer follow-up on the patients on that study as well.
Thanks, Gopa. Another question from Josh.
Hey, Gopa. Thanks for presenting and great work. Can I ask you 2 questions? One, ERCC2 seems to be the central gene, but there's some disagreement kind of going away from that as far as what other DDR genes, depending on the assay, the biomarker, or the patient. So maybe you could just tell us what are you currently thinking? I know, again, ERCC2 seems to be consistent, But outside of that, it doesn't seem to be as consistent as far as the genes involved. For example, ATM, RB1. Again, depending on which platform, they seem to be some variability. And I guess my second question for you is allele frequency. And is there any way to look at that, since you have the reads, to know is a higher allele frequency of ERC2 maybe associated with better response as opposed to like a minor mutation? Thanks.
Yeah, I mean, both are great questions. And I think question number 2 is something that I can definitely answer a little bit more definitively because we have looked into that. At least in this study, there doesn't seem to be a clear correlation between allele frequency and the presence of, and downstaging. We are doing sort of like additional analyses, like a copy number analysis or facets analysis to see if there's loss of heterozygosity of ERCC2, especially in some of those mutations that aren't associated with downstaging and path CR, to see if that might make a difference as well. So I think more to come. But your first question, I think you're right. I mean, you actually have alluded now to multiple factors in terms of the platform, in terms of the specific gene, and in terms of the actual mutation, that are all factors that result in a lot of heterogeneity in terms of what is the optimal biomarker in terms of DDR gene alteration or a specific DDR gene. I guess for me, ERCC2 primarily because that's the one that seems to be more consistent across at least 2 to 3 retrospective studies to have been associated with downstaging. So I think that for sure. We also have functional data from Kent Mao, and others that have shown that when you have these mutations, they do impair nucleotide excision repair function. And I think that's really critically important. That's something that's probably the next step in the field, is that, could we do additional in vitro assays to functionally validate, alterations in some of the other genes to really be able to delineate what's important and what might just be a passenger. ATM and RB1, those are really challenging because they are relatively larger genes as well. And so it's possible that a lot of the genetic alterations that we see in those in a high TMB tumor type may actually just be passengers or may not really be actually important for chemosensitivity. So I think, a lot of work still needs to be done about those.
Thanks, Gopa. Just for everyone's information, Betsy Plimak's group at Fox Chase has run KERAS on a subset of these same samples. Kathy's the one who analyzed all the downstaging and survival data. So if you have any questions about comparisons between platforms, Kathy or I could answer your question. Okay, we're going to move on now. So another opportunity to leverage the 1314 biospecimens is to look at germline. And today I'd like to welcome Mila Prokhnina-Olsen from NCI. She works with Andrea Apollo. A lot of us know Andrea as a colleague and clinical trialist of significant impact. Mila, take it away.
Thank you so much. Can you hear me okay?
Yes.
Okay, I'm very happy to be here, and I would like to share with you some observations we have, and hopefully we can find some common grounds and explore this question in more detail. So we work on germline genetics, and we are doing genome-wide association studies and follow them with different functional assays, and then we are trying to translate these findings into something which would be relevant for you, for clinicians. So there is a germline deletion of the whole GSDM1, which is 20 kb deletion, and it's one of the strongest risk factors for bladder cancer. And the classification I'm going to be using here is wild type. That means there is no deletion. There is 1 copy, or there are 2 copies. We call it null. That means that both alleles are deleted and there is no GSDM at all. And this null outcome genotype is extremely common. It's actually major outcome in Europeans and Asians, and less frequent in Africans. And this GSDM1 null status has been associated in GWAS, and this is our recent latest results, which we will update soon in publication. But counterintuitively, so increased risk of bladder cancer is also associated with better overall and progression-free survival in TCGA, adjusting for multiple variables. But as you know, it is mostly in treatment naive or non-NAC patients. So this is something I'm not going to talk about now because it looks like it might be a little bit different biological story, but what I'm going to be talking about is more about what else GSDM1 might be doing. So it's enzyme, and what it does, as a phase 2 detoxification enzyme, it is participating in detoxification of various carcinogens, exogenous, endogenous, environmental pollutants, and oxygen species, which is good for prevention of bladder cancer, but it's also something it detoxifies anti-tumor drugs. And this is what we were interested in. And then also another function of GSDM1 is binding testosterone and estradiol. So we were thinking, could there be any sex-specific effects? We were looking for any data sets that would have enough data both on treatment outcomes and socio-demographic data, and also something that we could use to infer GSDM deletion status. And this is the paper we found, and we kindly received data from Peter Black on this data set, including detailed clinical data, and it happened to be also very enriched for women involved in this study. And unfortunately, they didn't have any germline data, and we inferred GSDM status based on expression. And it's a very busy slide, but just to give you a very quick summary, is that basically we don't see any association with pathologic response, but we see some associations with overall survival and progression with survival and recurrence. And it's not in the whole data set, and it's not in men, but we see actually an interesting trend that all the associations and trends are flipped for women. And as you can see, it's not reaching significance completely. Well, it's not completely, it's not reaching significance, period, but the trends are completely reversed. And that's what we were interested in. And this is also in a total data set. And as you can see, we broke down by major treatment groups, because it could be that this makes a difference. And you can see that the trends is similar in at least in these two largest groups, especially in Gen Cis, and both in men and women. They are comparable in different groups, at least in this treatment. So this is a little bit different way to look at it. Looking at men and looking at women, you can see that there is definitely some difference. This is looking at all treatments together, including which are not so in a larger group, and the trend is flipping, and it's reflected also in recurrence in PFS. So we were thinking that, okay, why could it be? Would it be because women and men receive different number of treatment cycles, or women with GSDM or without GSDM receive a different number of treatment cycles? And it happened to be, it is significantly different, and women received less, fewer cycles compared to men, and also women with GSDM wild type received fewer cycles compared to null. So that's kind of not what we were expecting, but the hypothesis is that it could be some gender-specific effect, and the GSDM null genotype makes these women more tolerant to receiving this treatment. Since they received more cycles, but the treatment somehow is not as efficient and harms something else, which leads them to or towards survival outcomes, but without affecting pathological response. And by the way, we tested a number of different covariates, and some covariates like molecular classification was not associated in this analysis. So what we would like to do is to do genotyping in additional samples we could find. And as I mentioned, this is a 20 kb deletion, which is actually very difficult to work with, and that's why it was really overlooked for a long time. The last reports were based on really just PCR and RFLP and some Western or Southern blots. But this is difficult because there are duplicated regions and there's a deletion. But what we did, we developed this Tuckman assay, where we could easily and very quickly determine the genotype, so to say, as deletion, no deletion, and homozygous deletion. You can see they are clearly separated. You can easily see them, and we also use a number of controls, and we do it in 5 microliters reactions in 384 plates, and we validate it in a number of samples, already on several thousand samples. And there's also some differences, clearly you can see, between European, Asian, and African ancestry. So what we are proposing is that we would like to expand our cohort of women treated with neoadjuvant treatment, and of course we will be comparing to men, but the main goal is to really expand more a population of women, because it's a group which is often overlooked in analysis, because there's never enough women in the study and they are excluded because most likely they will also be receiving less treatment and maybe dropping off more. So we would like to study additional samples, if you could share them, and we would genotype these samples for GSTM1, and we can also do it from existing whole genome or whole exome sequencing data, and potentially even from RNA data, RNA expression data. So we would look at pathologic response, even though we don't expect it to be associated with GSTM status, but mostly we are interested to confirm our preliminary observations about survival outcomes, both in overall and sex-specific and treatment-specific analysis, and also then combined with results we already have by joint analysis or meta-analysis, and we would consider various covariates, most important clinical and demographic, and anything else you would find available and useful here. Thank you.
Thanks, Mila. So we need to, I guess, ask you if you could be satisfied with going in a 2-step process with looking at RNA data first, and then going on to perhaps validate it with DNA. And I guess the second question might be for Kathy. How many women did we enroll in the Coxsackie trial? And would we have enough power in the Coxsackie trial to do this? Maybe more generally, we're going to have to, as a research community, recruit more either retrospective or prospective samples from women. Any questions from the audience? So while I turn this over to Monty, who is going to lead the renal part of this, I received an inventory from Aaron Grundy at Nationwide, and we actually have a lot of blood-derived tissue available in the bank, particularly for some big prostate studies. Some of it is whole blood that was just frozen, and I asked Aaron if they'd isolated plasma from whole blood that had been frozen this way, and they indicated they have not successfully done that. But, again, based on the discussions we've been having about circulating biomarkers, I'd like to have some conversations in our TM calls about how we might be able to better exploit the resources that we have in the bank. So stay tuned. Monty?
Thanks. I'm actually going to very quickly pass it on to one of my colleagues here, but I'll just offer a couple of very brief updates. So Brian Shuck couldn't be here. He's with a sick child at home, unfortunately, but he's really been doing a tremendous job with the PapMet samples. He's been updating us regularly. He has about 100 of those specimens ready to go and, do the pre-specified sequencing in based on his BISQUIP grant. So, that's coming soon. We've been interfacing with Kathy and with Sam and the stats team on a proposal to look at pathologic discordance in PapMet. So, characterization of type 1 versus type 2. Abhishek Tripathi, who's now with my institution, is going to be working on that. I wanted to bring up to the podium Dr. Shuchi Gulati, who I actually met just pre-pandemic as my ASCO virtual mentoring program mentee, in fact. And so we first met there, and she's a rising star in the field, and recently was recruited to join Lucky's practice at UC Davis. And simultaneous with that, I think you got your K08 grant award. She's also gotten an ASCO CDA. And so many great things to come, but she'll update us on some of the ongoing translational efforts from Everest.
I think it's a different deck of slides for the translational medicine. I have it in my email. I emailed it to you. Can you log on to the email? Or?
Can I suggest this? Looks
Maybe
like
I
we're
can just
just trying to
talk.
locate. Yeah, maybe if you don't mind, you could just
Yeah.
speak to it. Is that okay?
Yeah, totally.
All right.
Thank you so much, Monty. I'm going to quickly run through some slides talking about, and we don't have the slides apparently. I'll just talk about the work some of the work, translational work that is being proposed for Everest. Dr. Ryan is going to talk about the phase 3 Everest adjuvant study in detail tomorrow, but briefly, this was a large effort through SWOG, a randomized phase 3 trial looking at everolimus compared with observation in patients with high risk localized kidney cancer. So the numbers off the top of my head, if I remember it correctly, we have more than 80% patients who signed up for specimens, and we have more than 800 patient specimens from this trial that are available for analysis. In addition, we have about 700 samples from plasma samples from the same patients that were collected at multiple time points. So it's a rich resource that can be utilized for a bunch of correlative studies. So in kidney cancer, our biggest struggle, as everyone in this room is familiar with, has been to identify what is the best biomarker for prognosis or prediction of response to the new therapies that are evolving. And we all know that genomics or DNA mutations have not really panned out in kidney cancer. We've tried to look at several genomic analyses in the past. We've tried to correlate them with responses, and they haven't really panned out. So there's been a few RNA transcriptomic signatures that have been proposed in kidney cancer. One of the recent ones was a paper that came out of Motzer's group, and they looked at metastatic RCC. They were able to define 7 specific groups, and that is the basis of a prospective clinical trial that Brian Riney is going to open very soon. In the adjuvant setting, in the localized setting, we have 3 signatures that we are proposing to validate in this tumor set. There's a 16 gene recurrence score also from Brian Riney's group. Then there's a 34 gene, it's clear code 34, which divides kidney cancer specimens into CCA and CCB depending on good or bad prognosis. And then there's a third cell cycle proliferation score that came out of University of Michigan from Todd Morgan's group. So the intent of this analysis, the primary objective is to validate the 16 gene recurrence score, because that seems to be one of the most robust biomarkers in the kidney cancer space. And then as secondary objectives, we will also validate the other signatures that I was just referring to, because they have been studied and it would be good to validate the pre-existing signatures. And I know Kathy has been extremely helpful. She's worked with Brian, and I saw some statistical analysis. I'm not in a position to talk about them, but I saw that there's a detailed statistical analysis that's been done for both the primary and secondary objectives. So hopefully using, and then Brian also wanted me to mention that there's a specific study that looked at PTEN mutations. This study came out from the RECORD-3 study, which was a comparison between sunitinib and everolimus in metastatic RCC. And they found that instead of the mTOR1, or the TOR1, TOR2, and the previously other proposed genes that were thought to be driving the mTOR activity don't actually predict outcomes when patients were treated with everolimus. Instead, it was a PTEN loss or gain function that was being associated with better or worse prognosis. So we are proposing also to do some IHC analysis to validate that finding as well, because that seemed pretty robust in the paper that was published. So in addition to the signatures, some IHC work, there's also scope to potentially validate some of the work that I've previously conducted at Cincinnati and now at UC Davis, where we have a gene signature, because kidney cancer, as we all know, is a very metabolically driven tumor. And so we found this 23 gene signature, which is able to stratify patients into good versus higher risk for relapse after surgery. And so since all the transcriptomic data is already going to be generated with the efforts that we are going to be doing, it's a good scenario to validate other signatures and do other correlative studies in this context. Also there's the plasma specimen. There's a scope to do some liquid biopsy and ctDNA MDR type analysis as well, which is not formally has not been formally incorporated, but there's scope to do that as well. So for this analysis, there's an ongoing collaboration with Veracyte. It's a vendor, a commercial vendor, and hopefully through that collaboration, it'll be easier to get the results, and it'll be easier to then disseminate those results as well. So yeah, that's it. If anyone has any questions, please reach out to Brian, Monty. I'm really thankful. I just want to mention, so Brian, Monty, Ryan, and Dr. Lara, they have been really instrumental in helping me get plugged into this analysis, given that there was some validation that I could do with my own signature with the ongoing study. So if there's, I just want to appreciate this opportunity, and hopefully we can come up with some really good, interesting results from this data.
As many of you in the audience have guessed, this was really just a test to see whether or not you could present this without your slides. So excellent job, excellent job. Really well done, really well done. No, I thought that was perfectly described. You gave a brilliant summary, and things are well underway to look at the tissues from Everest. I think we have a good sort of plan ironed out, and we look forward to presenting updates at the next meeting. Any questions? I think I'll pass it on then to Amir. Is that right, Dave? Nothing on prostate. Okay, very good. Peter.
I hope they're there. So just a reminder, the cancer control committees, any ideas, always happy to help connect you with the appropriate committee. Just to the agenda, we're going to dig a little deeper into S1600. We haven't had an update for a while, and talk about an active surveillance protocol and a couple new concepts. The current studies, besides those two, S1823, which is a biomarker study for prostate, really, I think, accruing quite well. No major issues with this. Any questions on that study or anything? So, and then the other one is the iCheck-It study. I don't think Dr. Kudero was maybe going to try to come, but also looking at immunotherapy toxicity, across several tumor types. I think accruing really very well as well. So I think next we have Dr. Hamilton Rees here to kind of give us an update on S1600.
Hey, thanks, Dr. Van. And oh my goodness, I'm so happy to see all of you. It's been a while. It's been a long minute. So I am going to give you some updates on S1600. It's been, as you know, a challenge to run a trial during a pandemic and all of the challenges and adventures we get to go on together. So I thought I would remind you about what this trial is trying to do here. So many of you are treating patients that are undergoing radical cystectomy, and so you're very aware of many of the common nutrition-related complications, such as malnutrition and sarcopenia. As we've learned more about the immune system and ways that we can prime the immune system and use it to our advantage for treating cancer or learn more about it for preventing COVID, the role of nutrients have become more and more clear in helping with immune response. There was a great paper in the last year that delineated fractures that are related to radical cystectomy. And so thinking more long-term, we have been focusing a lot on acute issues with radical cystectomy, but I think that's important as we look down the road. And then the very common GI issues, bowel function, ileus. There's been a ton of research that's been published as people have had more time to write about the role of using the gut, also fluid-directed therapy. And then our primary aim in our study is looking at postoperative complications. And I'm going to remind everyone of kind of the conceptual framework that we're using with that. So S1600, our goal is to get 200 patients on trial. We have 150 now, and I need your help. So if you know someone or know someone who knows someone, please spread the word that S1600 is open. Our primary outcome, as I mentioned, is looking at postoperative complications 30 days after cystectomy, and we're looking at lots of different secondary outcomes as well as some more translational and correlative aims. This is our schema. Essentially, the tricky parts of the trial are screening for malnutrition. Not everyone has a process in place for that. We can help. And once you screen for malnutrition and the patient agrees, we randomize, and then the patients take the drinks for 5 days before surgery, 5 days after surgery, and then 30 days after surgery, we get postoperative complications from those patients. The other tricky thing is that there are DEXA scans because we're interested in muscle and body composition. So this is our current enrollment, 150 patients. We've had really excellent recruitment across the nation. As you can see, USC really took off sprinting. We have 61 participants that they've enrolled, and Henry Ford, Fred Hutch, and Mayo, Florida. I mean, just thank you so much. And those that have enrolled one and got them through, it is a huge help. So if you're at a place where you have approval to put a patient on, we are here to help you and walk you through that process. So don't hesitate. As I mentioned, the tricky parts of the study, so there's DEXA scans. There were some confusions about how to order those. These are not scans that are meant for diagnosing bone issues. They're body composition scans. So I have the CPT code there. PGSGA, we can provide training if you are not familiar how to do that or you don't have staff that help you. The research blood draw, we have some kind of tricky things because of the correlative aims, and I realize I'm talking to my people here, so you understand how these things, it matters to have them on the same day. And so that has been a little bit tricky. There's stool microbiome collection kits as one of the correlative studies. Those are really straightforward as well, and then we are open to Spanish-speaking patients. This is the conceptual framework that we've worked with over the years. So that's Dr. Holzberlein and then the immunologist that worked with me to develop the concept. And essentially the idea is that if you undergo a huge surgery, that of course is going to trigger the immune response. It shifts the Th1, Th2 balance, releases a bunch of myeloid-derived suppressor cells and a pro-inflammatory cytokines that can diminish arginine circulate in the circulation, which affects a plethora of things. And that combined with the pro-inflammatory cytokines leads to the muscle wasting. And then many of the arginine deficient kind of mechanisms affect aspects that would touch on postoperative complications. So that's why we have a composite primary outcome. And then just a quick reminder, again, after surgery, arginine is metabolized mostly to that Th2 side and metabolized, and arginine depletes in the blood supply, which is needed for T cell proliferation. And that is why patients are a little more susceptible to infections. One of the reasons that patients are more susceptible to infections. This was our pilot study that helped you all believe that this might be possible. And just a reminder of that pattern of MDSCs, that they peak that time point 2 days after surgery and then tend to come back around the 30-day time point. And then also that we had found that antibiotic use was significantly different between the immunonutrition group and the control group. These are our raw data from our current study of S1600, so they're not, of course, it's not unblinded, but I do have our internal site versus external sites. We've been doing a lot of quality checks to see how the data look, and we work with an immunologist out of LSU that is helping us with those. So the data are coming through, and they look good, even though we're shipping samples and running them day after. And so I just wanted you to know that all that work that you're putting in is leading us to getting the results that are going to tell us an answer. And then the last update I have is that we really hope to complete enrollment by the end of May, and we have 50 more patients to get on trial. So again, this is my begging and pleading that's a little bit shameless to try to get patients on trial. We do have 2 more years of funding that we got from the NIH from a grant that I had put in last year at this time. And essentially, this is going to help us do a deeper dive of studying the gut microbiome and changes either as a direct or indirect effect of those nutrition drinks. We're working with a statistician and an integrative physiologist to help us look at DNA methylation-based immune profiling, which is really cool because it might allow us to see complete immune cell types, like a better profile of what's happening without having to go through all of the hoops that we've gone through with running flow cytometry in the samples. So it could be cool for some of you guys too. And then the last thing is looking at some of those associations between the gut microbial diversity and the immune landscape as potential mediators of complications or postoperative infections. And that's my team that talks with you guys over the phone and emails and receives blood samples. And I can take any questions.
All right. Any thoughts or questions?
Oh, here's a question. Great.
So I think your preliminary data look really exciting. Are you getting the tumor tissue by any chance?
We are not getting the tumor tissue.
Okay.
Isn't that a bummer?
It is. That may be in urine, just to look at the microbiome there too, but
I know.
future study.
Right? I wish. You know, hindsight is always 20/20. It's one of those things like, we want everything. Oh, wait, this takes 3 years to get this thing off the ground.
Exactly how you feel.
Thank you for your question. Any other questions? Rick, I've missed you.
Hey, how are you?
Good.
See you on Facebook. So I love this trial, as you know.
It only happened because of you. Thank you.
Well, I can't take any credit. So your target is May.
Yeah.
How realistic is that? What's your current monthly accrual rate, roughly?
So, you know, the thing with trials and what I tell my team is that it comes and goes in waves.
Yes.
We don't have a nice metronome pace. And so USC has not enrolled a patient in a while. They kind of lead to like the tsunami waves of, Sia will send me a text message and he's like, I enrolled like 7 patients today, which is fabulous. And my team is like, but we welcome that. And so that has slowed us down. I don't think it's the fact of like competing trials. I think it's competing time. And I really appreciate everything that you guys do to make this happen. This group is incredible. I can't say enough good things about SWOG. So yeah, I think it is somewhat reasonable. I think to get to your question, it is possible, and I need help.
Okay, so you know you have my help, and everybody in the room has my help, because we need to do this.
Thank you. Anything else? All right, thanks for your time and attention.
Great. Thanks, Tim. All right, next we have Dr. Nagi Kumar from ECOG Akron to talk about her active surveillance study.
Is it on? Yeah, it's on. Okay, thank you everyone for coming today. And I came just to speak to this group from Florida, Tampa, Florida. This is a trial that we opened based on our work as well as that of others. We've been developing agents for primary and secondary cancer chemoprevention. And this is one of these agents that was a go. I mean, we did the screening, the epi work, the in vitro, vivo, preclinical models, and then went to an early phase trial, and that has taken us to this stage. Just wanted to, preface my brief presentation on how we develop agents for cancer chemoprevention. This is a phase 2 randomized double-blinded study of green tea catechins. We have an IND for this formulation compared to a placebo in men on active surveillance for prostate cancer. In this study, we are looking at modulation of biological as well as clinical endpoint biomarkers. The hypothesis is based on the available evidence. We hypothesize that men with biopsy-proven adenocarcinoma of the prostate who are on active surveillance for low-grade or intermediate-grade prostate cancer, Gleason 3+3 or 3+4, I'm sorry about the typo there, who receive a standardized formulation of green tea catechins with the most bioavailable and bioactive catechin being EGCG at a dose of 800 milligrams per day for 6 months will have a significantly decreased rate of clinical progression. And how did we come up with that? It's also based on our preliminary work. We hypothesized that the primary pathway by which green tea catechins modulates the clinical progression is via the proteasome inhibition pathway by decreasing NF-kappa B activation and accumulating I-kappa B alpha and P27 proteins, resulting in induction of apoptosis as well as decreasing proliferation. We've shown this in vitro as well as in a preclinical model, and these studies have all been published. So the primary objective in this trial is to compare the change in the percentage Ki67 expression in the biopsy, in a biopsy core positive for cancer from baseline to end of study biopsy between men who are on the agent compared to the placebo. And of course, all of them are on active surveillance. The intervention period is 6 months. How would we measure the percentage Ki67? Because the pre and post may not have the percentage Ki67 in the same core that we did the baseline positive core. So the primary measure will be change in the highest percentage Ki67 measured in the core positive for tumor from baseline to the highest Ki67 in any of the cores positive for tumor post-intervention. The secondary endpoints in the study are to assess apoptosis by caspase, as well as to assess percentage of Ki67 to apoptosis in the end of, from start to end of biopsy by treatment arm. The other clinical outcomes would be to evaluate the number of biopsy cores positive for cancer at end of study by treatment arm, and the percentage of any biopsy tissue core positive for cancer from end of study biopsy by treatment, and to evaluate percentage Ki-67. And we have a lot of these variations because we want to do also post comparison other than just the with treatment from beginning to end comparison. We'll also look at safety markers. We have other exploratory objectives to look at plasma levels of these catechins. We've done this in prior studies, and the only catechin that really shows up in plasma in patients who are taking the study agent is the EGCG, the bioactive catechin that we are evaluating in this study. We also have patient-reported outcomes, which is lower urinary tract symptom scale, as well as the quality of life. All patient-facing instruments are also available in Spanish. Here's the study schema. Men on active surveillance who are on prostate with 3+3 or 3+4 will go through this process of pre-randomization. All their pathology slides, as well as their pathology report, will be sent to a central pathologist for verification of the Gleason. And also the pathologist, the central pathologist will mark the region for evaluating the Ki-67 in the course positive for tumor. And we'll stain it and send the result back to the sites within a week. The criteria for inclusion is, of course, the Gleason plus Ki-67 in any one of the cores at 3 or above, percentage Ki-67 expression 3 or above. We discussed this a lot with DCP, National Cancer, NCI. It took 2 years for the study to get funded, and there was a lot of back and forth about these issues. We will stratify the before randomization by Gleason, as well as the number of biopsies historically that the patient has had. And at the step 1 would be randomization if they meet all this criteria. And also, of course, because there have been case studies reporting liver toxicities in patients who took very high doses of green tea catechins for weight loss. So you have to remember they also took it with caffeine. The FDA has required us to do LFTs at baseline, at midpoint, and at end of trial. So anyone with Hep B or C history or any liver function abnormalities will not be included in this trial. So they'll be randomized to arm A or arm B. The intervention is 6 months. At end of intervention, they'll have a standard of care biopsy. The tricky point here is men on the key eligibility criteria is men on active surveillance who are already on active surveillance, who will be having a biopsy coming up, a standard of care biopsy or a follow-up biopsy coming up, are the ones who will be randomized into this trial. And that's the confusion, because they don't know, the sites call us and say, we can't biopsy the patient now and then biopsy them again at 6 months. But the criteria is to include patients who are already on active surveillance. So the baseline biopsy is the last biopsy that they've had while on active surveillance. And that's the reason why the number of biopsies would be one of the stratification factors. They could be on active surveillance for 3 years, 4 years, however many years prior to this intervention. I think that's been the a sticky point in this trial. Again, I think the other point that the sites brought up was, can we have any kind of biopsy? Should it be a 12-core? Especially patients who've been on active surveillance for a long time may not get a target, may get a targeted biopsy. And if they don't have a target, they may get a 12-core biopsy. But not everyone was doing a 12-core biopsy at every follow-up visit. So these are the points that have been raised, and we'd love to hear from sites that are willing to give us that input, and we're willing to make that amendment. And again, the serum PSA should be below 10. That's a criteria for active surveillance anyway. We've had a lot of challenges. I think we've all talked about that. The study was suspended for a while, back on COVID-related challenges, and people not opening prevention trials because of the number of the turnover of employees and their CRUs and the CTOs. So we've had a lot of those kind of challenges, but I think we're back on track, and we have started recruiting. I get a patient a week, which is exciting, but we need more patients every week. The study complexities have been really looked at very carefully, and we've made 2 major amendments to the protocol, so it's easy for sites to understand and recruit. Again, this is I do SIVs for sites that want me to do it, so I clearly tell them how to get ahead of the game. For example, here, establish pre-screening workflow at sites, generate a list of potential subjects on active surveillance who are coming up for their follow-up biopsy, set up a call schedule and present the study to the participant like 7-8 months out, so we can screen them, see if they're eligible, so we can randomize them 6 months prior to their trial. So 7-8 month window prior to their standard of care follow-up biopsy would be ideal. So these kind of, and we really get back, central pathology is at the Moffitt Cancer Center, and we do get back to them within the week. So the total number we need at the end of the study is 216. We just, as I said, we have activated the trial last year, but nothing happened because of every site closed, they wouldn't even open trials in many of the comprehensive cancer centers, but we really are moving along right now. I think we developed a lot of site tools, as you all have done, investigator referral letter, FAQs, patient study summary. We have a lot of clinical education to the trial groups. I do that 2-3 a month now, and we've made a lot of protocol amendments. July 22 was our last amendment. We also spoke to Dr. Marshall and other people who developed the meal trial, which was very similar. The target population was very similar. So we have talked to other people who've done studies similar to this. And one of the things that they brought up was get a champion for each of the groups. So we have Dr. Trebeluzzi, Ed is our champion for ECOG, NCORP. We have several administrators. We're still picking a champion there. The ACTs, the VA sites, they are opening up now. They wanted some kind of a MTA to send us the slides. That has been resolved, and they are opening the study in the VA. Alliance, we have Jim, we have Dr. Morris and Dr. Adams Campbell and Dr. Paskett, and in SWOG we have Dr. Cobb. So I think we are ready to roll, and I hope many of you would be interested in this trial. I'd be glad to take some questions. Please, this is my study contact. Thank you.
I have a question. Great presentation. Thank you. Very interesting. So the question is about the logistics. So you enroll a patient 6 months before the next standard of care biopsy, but 6 months ahead of time, you don't know if the biopsy is going to be in 6 months, 7 months, 8 months. You don't know exactly the date. So does the treatment continue until the day before the biopsy, whenever
Yes.
that happens?
Yes.
So it's not exactly 6 months.
Yeah, but we would like for that window to be plus or minus 15 days, but
Right.
so we recommend that you recruit them well ahead of the 6 months because the intervention should be 6
Right.
months. And the reason why we went with the 6-month intervention is because this is a phase 2 and we didn't know what would happen in a community. I'm running the same trial in a single site at our site, and it's a 2-year intervention. But in the community, like an NCORP setting, we didn't think that would be feasible. And if this trial went to a phase 3, the real world setting, we wanted to know whether it was feasible. And that's the reason why the national trial got approved. And yes, ideally would be 8 months before the standard of care biopsy is going to be scheduled, is when we think you should do the screening.
Second question would be about contamination. Is it possible that patients could get this compound or this by going to a GNC store and getting this outside of the study anyway?
No,
or drinking
no,
green tea? Pardon me for my ignorance on that.
Yeah, so we give them a list of foods that they should avoid, and it also includes supplements. But most of the supplement industry, as you all know, 90% of that is junk out there. So they are inactive compounds. So we're pretty confident. We have tested many of the compounds that patients bring in and has no bioactive ingredients.
So Dr. Kopp, who's our champion, is actually online. So did you want to weigh in, Ryan?
Yeah, I just wanted to add to that. I think many of us who do a lot of surveillance, we routinely check PSA on these patients, usually every 6 months. I know in our university, basically we have a standardized workflow where particularly our PAs are often seeing these patients on that 6-month interval. And that's really the time to recruit these patients, particularly if you have any standardized protocols for when they're getting a biopsy. So, for example, our clinic, it's every 2 years. So that PSA visit that is 6 months prior to that 2-year biopsy is really the perfect time. And granted, there's a lot of variability in terms of how people do surveillance, but I think periodic PSA monitoring is fairly standard. So, whether it's your own clinic, whether it's a PA or NP or even a nurse who's doing that follow-up, that's really probably the best time to catch those patients.
Absolutely. All right, great. Well, thanks.
Thank you.
Thanks. Next, we have Alejandro Riccio. I'm going to present his idea with regard to looking at sexual dysfunction post-cystectomy and hoping to get input from everyone.
Thank you, Dr. Van, and thank you to Dr. Pramindra for this opportunity. I do have a set of slides, and I would like to say that I'm at the University of Arizona Cancer Center, and I am assistant to the director of the Community Outreach and Diversity, Equity, and Inclusion. So it's kind of what I like to do. If I can have my slide. Oh, I have to change it myself. Okay. So this is for women's sexual dysfunction after radical cystectomy. They have done this in men, focus comparison between, I'm sorry for the typo, iliac-condylar urinary diversion versus orthotopic neobladder substitution. So a few things that I'm gonna hit here. So we all know that, the bladder cancer, according to the database, is gonna be about 81,000 expected this 2022, and 25% more or less is gonna be women. We all know the indications of radical cystectomy is, basically those who are non-metastatic, who can be, judged to be removed. But there are also, indications for very high risk features that are persistent recurrent disease, even though they are not muscle invasive. So I'm gonna just talk about this in male. They did this trial and they have never done it in females, and this was in 2010. They found that orthotopic ileal neobladder offers a better long-term results in erectile function and sexual desires after radical cystoprostatectomy, and who compared to the one who had ileal conduit urinary diversion. Now the caveat is that it was done in 2010. Design 2006, 2010. There was a lot of new adjuvant. It was just a straightforward surgery idea prospectively. There was only 80 patients, 40 each arm, and they did find 3 times improvement using the neobladder, like in erectile function. It was 45 against 10%. Sorry, that's sexual desires, and erectile function, it was about 20 and then 8%. So, but females, they are offered open radical cystectomy, and they are removed some gynecological organs, including the uterus, the fallopian tubes, the ovaries, and the anterior vaginal wall. And nowadays they they have developed these pelvic gynecological organs preserving techniques that they may be applied. And this female sexual function was preserved on those who receive also the new vascular preservation. So female sexual function after radical cystectomy, it is crucial, right? It's something that more and more is an interest, but it's overlooked. We can see that, in recent 2020 systemic review, where about 37, articles were reviewed, only 10 had, some women sexual function data collected, and now those were also men. It was only about 4 dedicated for women. And these women are receiving, they concluded that women who are receiving orthotopic neobladder tend to be younger, they tend to choose that, they tend to be more sexually active, after surgery, and they report them having higher physical function, and in the self-reported PROs and quality of life. So that's kind of what we have, and this also kind of outdated data. So 31% of the women, they are reporting when they are asked that they continue to be sexually active after radical cystectomy. And, in this survey, most of urologic surgeons, they are not talking about that with women, and perhaps, they were talking more with men about this. So sexual function is an important and overlooked thing that a woman's survivorship needs to meet. So the more I thought about it, there is a lot of complications here that I can point out. The simple hypothesis will be there is no difference, right? You get one or the other one and it will be the same. But the alternative hypothesis is that we think that neobladder will, provide women a better sexual function than ileal conduit diversion. The sample size I did not have calculated, because it's an idea, but I'm gonna guess if we just look at the men, it was about 80 patients, and we will need to do a lot of statistics. And why it became a little bit more complicated? Well, this has to be a prospective study. The first question that I was in my mind is, are we going to include the muscle invasive, or are we going to include also the high risk and persistent, high-grade urothelial carcinoma that are planned for radical cystectomy, and they have resectable disease that determined by the surgeon. But as I said, now the current standard is that to provide them new adjuvant systemic therapies, and those can also, provide less sexual desires and function. Now approved as well adjuvant systemic immunotherapy that can also be a variable here. So then, I'm thinking that the only one that are going to be clean are going to be the high risk, persistent, recurrent, non-muscle invasive, but there's going to be a really small group side. Women have to report to be sexually active, so they tend to be younger. And we may exclude the more elderly, but patients have preference, and surgeons will decide what they want. And at least on my side, and what I have heard is that there are more ileal conduits and neobladders. So are we gonna cap? Are we gonna fix this? How are we gonna do it? The only women's sexual functional health questionnaire that I thought it was commonly used and validated is this one. So I'm proposing that one, but I'm happy to hear more options if anyone knows a better one. They used to collect, 4 weeks before, but that was when there was no neoadjuvant. Are we gonna, collect during neoadjuvant? We usually tend to say that, it's not the time to have sexual encounter, or you have to use protection. Or are we going to extend it to after they completed the adjuvant, 2 years? So there is a lot of things that are kind of variables that I need to clarify, and feedback is always welcome. The best way that I think of this is, it will be really hard for me just to do it in my institution or two institutions. We really need a collaborative group that can help us to collect data, because we need more people to be involved. And so that's why I'm bringing it here. Thank you.
So any thoughts? This is a focus of the survivorship committee. I think it would flow through their committee, but really want people's thoughts and interest in developing it.
Excellent presentation, Alejandro. This is actually an important topic because this came up at the Beacon meeting also this year, and it was highlighted. I think we need to figure out a way to first collect this data, maybe on some trials which are going on, like Jill's trial is going on at 1600. If we can collect that data from that trial on females who are getting neobladder, or maybe some upcoming trial with like Josh Meek's trial in radical cystectomy and different neoadjuvant therapy based on subtypes. Maybe we can collect ONB and ICD data on women, younger women on this. But certainly we need to collect this and see if sexual function sparing surgeries should be promoted, or how does it impact on the pathological outcomes. But this is a very important topic which I think needs to be explored here in the cooperative group.
Thanks for the comment, and I do agree. I will like to add to say, we didn't talk about this one, but also the organ preservation. How does that affect sexual function in the chemoradiation? That's another important topic that is not addressed here.
So as Parminder's pointed out, this is a really important topic, horribly understudied. I do have a question as to eligibility. So must this be a partnered woman, and must she have a heterosexual partner?
No. I would like to have more input on, because I do participate in diversity, equity, and inclusion, but I do not consider it has to be, male to female. It has to be sexual desires by her own perception, quality of life, PROs, and, sexual encounter by her own. Let's say the topic of vaginal dryness is regardless of who is your partner.
Okay, but you need to be a partnered woman to be in this study.
Good question. I'm gonna hold on that.
I'll let you.
I'm gonna take that too.
Currently, many of the some of the questionnaires that address sexual function ask and have differentials for like partnered women and unpartnered women, and so they do have like separate questions for just that exact point.
Thanks for that comment.
Hi, Seth Lerner. We have a meeting every month in local bladder. And the next one is next Wednesday, 5:00 Central. Would you be available to come talk to our group? It's virtual, it's a Zoom call.
Sure.
To present some of this, I'm kind of brainstorming about sort of how to go about this, and maybe we could talk in a little more depth. Maybe, Peter.
Definitely. If I always tell myself this is my calendar, I'll give priority, and I will be there. It's a Zoom meeting. I'm gonna guess, right?
Thanks. I'll send it to Peter. You can kind of.
All right.
Yeah.
Thanks.
This is terribly understudied, and it's an opportunity, and you've got a lot of smart people out here. Peter, let's do it.
All right.
Let's,
That's
you know,
actually-
what
yeah, I
it's
think-
going to ultimately look like. Kathy asked me, is it randomized and so forth? So, I mean, there's a lot of there's a dearth of information. Seth, correct me if I'm wrong. I haven't done a cystectomy in a number of years, but the knowledge of the anatomy is substantially less in women. So there's I mean, at least according to Larry, were the techniques less developed? No? The same? Or in terms of application, perhaps? No? All right. Yeah, of course.
I think you have to differentiate between high volume.
Yes. Right.
I mean, the same thing as the prostate cancer.
Correct. Well, but you have to, there's not a lot. This is huge opportunity. Very novel.
So I was going to ask, is there a validated questionnaire even specifically for this topic for females or not?
Now, this is not
There is
specific
not.
for bladder surgery, it's just a questionnaire for sexual function of women that is validated, but it's not for, after radical cystectomy for women.
So then this would be a big contribution and a big leap. So yeah, I think I really like this. And we should absolutely be doing this in conjunction with a number of our studies, frankly.
I think this is really exciting, and I've looked at this retrospectively in the TMT population, and which is even less well studied actually than in the cystectomy population, because mostly I think developing this questionnaire is really important because most of the questions on the quality of life PROs that are part of studies, whether it's at least in the TMT population, BC2001 or other RTOG studies, they almost always have like 4 questions for men and then like 1 question that could be used for either women or men, but nothing specific for women. And so I would think that this would be great for sort of all bladder cancer patients, no matter what the treatment modality, and I'm excited that you're looking at it.
Thanks. I do agree. There's a lot more information on men, even more questionnaires for men than for women.
All right, thank you.
Thank you everyone for this forum.
Yeah, and thanks for Parmender to get it on the radar. So, all right, last but not least, Clara Wang is going to, Dr. Clara Wang is going to present her idea on looking at cognitive function with ADT.
Okay, thanks very much. Thanks, I really appreciate this opportunity to present this concept to you. Just for some background, this is very, very new. This actually came out of a meeting that happened, I think, like 4 weeks ago. So we had initially been interested in this topic from an intervention perspective, but when we presented this with Peter, as well as some leadership from the SWOG Symptom Control Quality of Life Committee, the feedback actually came back to do a prospective study, so that's where this came out of. This is the title of the study, to look at the impact of ADT on cognition in a prospective manner. In terms of some background, I'm sure many of you are very familiar with this information. Prostate cancer obviously is extremely common, and ADT is an important tool that's used in ultimately used in more than half of prostate cancer patients. And quality of life is becoming more and more important to many of these patients, especially as therapies get better, patients live longer, indications expand, and also treatment is intensified. So quality of life becomes very important. In terms of cognition, subjective complaints of cognitive changes are fairly commonly reported in patients who receive ADT. About 25 to 50% of the time, these complaints are reported. They're in multiple cognitive domains. And biologic plausibility, there is data to support this based on, for example, functional brain imaging, where you can see changes as early as 6 months. In terms of some mechanistic explanations for this, there is a proposed effect of testosterone on amyloid beta metabolism, which of course is important seen in the plaques of brains of patients who have Alzheimer's disease. In addition, there are androgen receptors in parts of the brain which impact cognition. And then finally, ADT can negatively impact sleep as well as cardiovascular risk factors, and this may in turn impact cognition. So if you look at the literature that seeks to establish this correlation or association, there still is controversy because there's conflicting data both on the basis of retrospective as well as prospective studies. So the retrospective studies have been very, very large, but they're limited mostly because they're looking at a diagnosis of dementia. They're not really able to assess sort of more subtle cognitive changes, and many of the complaints that patients bring up really are not probably captured by these types of databases. There also have been prospective studies which are generally, better able to answer some of these questions using neurocognitive testing. However, their main limitation really has been their sample size. And as I said, data from these types of studies also has been conflicting. Just as a little side note, there really is little to no literature on how this may impact as we add novel hormonal therapies or chemotherapy to this. And so ultimately the conclusion from all of the literature is really that a large prospective study is really needed to answer this question. And again, that was the feedback that I got from the meeting from a few weeks ago. So, we put this together fairly quickly, but in terms of the objectives, so our primary goal would be to describe the natural history, the incidence and the onset of objective cognitive impairments that occurs in prostate cancer patients treated with hormonal therapies. And this would be assessed by serial cognitive testing, and we would compare this to controls. So other secondary aims, which would be to look at other potential variables that can impact cognition, such as whether they be clinical, neuropsychological, genetic, biochemical, et cetera. We decided, this is an older version of the presentation, so we subsequently decided to take out any neuroimaging because we thought it'd be difficult to get it paid for. Although we could put that back in, I suppose. And then the final thing here was to develop a risk model to predict cognitive change in these patients. So this is the study design as of last week. In the most recent iteration, we actually took out the benign prostatic disease cohort. And so as I mentioned, we really wanted to have a control group so that we could really determine what changes were related to the ADT as opposed to just aging. The reason why we initially included the benign prostatic disease is because, at least in some of the breast cancer literature, there's evidence that some cognitive impairment may be related to the cancer itself. And so that was why that group was initially put in there. And in terms of sort of these groups, there would be the prostate cancer patients who were being treated with ADT, and the duration would be for at least 1 year anticipated. Then prostate cancer patients who are not expected to be receiving ADT, that could be surgical or radiation patients, for example, even I suppose patients on active surveillance. And then these patients would be followed longitudinally and assess, this is obviously up for feedback at baseline 3, 6, 12 months. And I think in the next iteration of this, we had said to reduce this number yearly after that. In terms of the population we'd be looking at, so some standard eligibility criteria up at the top. We wanted life expectancy to be at least 5 years so that we would have adequate time to study cognition. In terms of barriers to cognitive testing, we suggested excluding patients who have CNS metastases, dementia, et cetera. And then in terms of the cohort-specific criteria, We want it to be very, very permissive, so to allow both metastatic and non-metastatic patients when looking at patients who are receiving ADT, to allow the enrollments of patients who would be getting secondary hormonal therapies, allow chemotherapy, and also allow co-enrollment onto other NCTN studies. In terms of the not-ADT cohort, as I said before, most likely prostatectomy, radiation, and active surveillance patients. For the benign cohort, if we want to include that, to require biopsy in the past year. So in terms of how these patients would be assessed, of course, we would want to look at other factors that can impact cognition, medications, comorbidities, look for reversible causes of cognitive impairment, substance abuse, family history, et cetera. And then there, towards the bottom, these are some factors which have been in the literature, so, may incline patients to getting Alzheimer's disease, specifically ApoE genotype, amyloid beta isoforms, et cetera. And then these assessments would be ongoing, sleep, exercise, food, depression. We did want to include at least one measure of subjective cognitive decline. There's a couple of questionnaires that we could use for this. The SEDQ is here on the slide. I promise also has, there's a subjective cognitive questionnaire as well. And then in terms of some biomarker, here are some proposed, in addition to the amyloid beta isoforms, also phosphorylated tau. And then I think, this is the cognitive testing that this is where we got help from Jeff Weffel, who has a lot of experience in doing cognitive testing in the cooperative group setting. And so, as I said, we would do this longitudinally. These are the 4 on the bullet points here: Hopkins Verbal Learning Test, Revised Verbal Fluency, Processing Speed, Executive Function, are well validated and have been used, like I said, in other cooperative groups. On discussion, we also wanted to add something called a mental rotation task, and although this has not been as well validated, the reason we wanted to include it is because one of the more consistent findings in the cognitive testing that's occurred so far is changes in visuospatial ability, and so this mental rotation would help to test that, even if it hasn't been as well validated or extensively used in these types of settings. So with that, I would just like to really acknowledge the people who helped me to put this together, and open it up for questions and feedback.
So, yeah.
Well, Mike should probably stand up. We just submitted a PO1 to address this using 40-oxetine as a intervention, which is affects we have some animal models that have illustrated. In fact, it's Dave Moralak. If you've looked this up, it's his interventions that have identified the location where it works. This is a great, Kathy tells me that this is doable within SWOG, an observational study. It's complicated, right? Because cognition and depression with ADT have a tremendous amount of overlap. And it's also complicated as to what your control group is. And it's also complicated because folks can cycle on and off ADT. And it's also complicated because it was Dawn Hirschman's study, wasn't it? And the intermittent trial, the continuous versus intermittent, that showed that, was it Carol's? That it was the Alzheimer's study that showed the difference in JCO that we published a number of years ago, a while back, that it needs to be a fairly long period of time before you can see some of the long-term impacts, and the problem is patients, like radiation patients, cycle on, cycle off, and is it duration and so forth. But this is if there's a group of folks that are interested in this, this would be a terrific opportunity. It's complicated, but be terrific.
Ian, there's a study presented at Survivorship by somebody from San Antonio looking at antidepressant as a preventative. Is that what are you gonna?
Maybe Jason presented
Yeah, Chapin, yeah, yeah.
He's from our group. That's the study.
That's the
that-
study,
yeah,
so we
yeah,
could meld them somehow. and
Yeah.
It's a good, Clara, great job. It's really undertreated, so it's really important. I can share, 2 or 3 cents on being part of a study, that Alicia Morgans and Chuck Ryan are doing, and actually doing that for ADT plus any NHT for the most part was Aburenza. And we, it's a year. And we were doing these tests like every 3 months. I'm not an expert to mention the type of tests we did, but I can tell you patients are in clinic between 2 to 3 hours. So that's one potential limitation, right? The enrollment was, was moving, but was moving slowly because there was one limitation. A lot of patients were reluctant to participate because it would be long, right? And then I would, perhaps think the match will be important. Your control is very important. I think things like duration of hormones is important. So I probably would just go, and then also, what do you, like, it's different to think of an anti-androgen or a CYP17 or none of that, right? Like the effect, if it crosses the blood-brain barrier or not. So perhaps a more homogeneous population, right, could be helpful. The follow-up, I mean, I think I had like 4 or 5 patients on that particular study, and I struggled a little bit to have them around for a year in terms of, being able to keep doing that. So, as we're asking for, more years, right, of follow-up for them to answer questions twice a year, if I saw it correctly. Maybe if in the metastatic setting, you're seeing more of those, but sometimes, in the early stages, sometimes they're lost to follow-up or other reasons. So maybe it will be another reason to just define, do that in a setting where you're more likely to see those patients, and I guess the loss to follow-up would be less. So anyway, I think it would be great to chat with Alicia because she definitely has a ton of experience because she's running that. So.
Very good points. Thank you.
Yeah, like Ian said, our site did a lot of initial studies. We did neuropsychological testing, which takes like hours to do. So that's really long. And then we tried MoCA and brain health assessment. There's tablets, there's all different types of things. But I think when we submitted our PO1, some of the criticism we got back was essentially that this wasn't fully established yet. So that trying to do the intervention when this wasn't established. And the second comment was pragmatic, kind of like what you were saying, that you can add on tons of stuff. So I think getting, what's the main focus, and then a lot of the biomarkers are really good right now. So I think doing some focus on biomarkers and genetics would be, I'd be
Right.
happy
No,
to
I
work
think
with you
most
on
of what
that.
I saw in the literature really had to do with Alzheimer's types of dementia, but it's not clear that that's.
Correct.
Yeah.
Like getting the cognitive defect versus dementia, and then those are different biomarkers, right? So I'm happy to work with you on the concept.
Yeah, I'll try to hunt you down later. Thanks.
Thanks for this. This is a terrific study. I would, I guess, suggest focusing on the patient-reported outcome side rather than having it be an assessment by a professional, like a research associate. I think NCI is really cracking down on patient-reported outcomes, and this could do a lot of good in allowing other investigators to add on cognition to those studies and moving those endpoints from an exploratory to a secondary. So if you have the data showing what the baseline, cognition problems are with androgen deprivation, et cetera, that would be great. NRGG 009 is using FACT-COG as a patient-reported outcome, and that could be much simpler than having someone do the actual assessment and save you some time. And then the only other point is, if you screen for depression or have depression as part of your patient-reported outcomes, you have to be really careful, I think, because what if you find somebody who's suicidal or there's something in there so that you and your study team are not liable for missing out on severe depression? Thanks.
No, that's a really good point. Yeah, I mean, I think I would like to probably keep some types of objective measures of cognitive change, just because there's a bit of controversy in the literature. When full neuropsych testing has been done, there's also, so even if these subjective cognitive complaints come out, they're not always validated with or they don't correspond. They're measuring different things. I think we wanted to definitely include a subjective component, but to match it with the objective testing as well too.
Yeah, I completely agree. The subjective will be very important because it's possible none of the tests can detect the cognitive changes that we all know we see in these patients. So I agree, Alicia Morgan's battery is extensive. That's why it takes 3 to 4 hours. So you could see if she's able to give you any preliminary assessment of which parts are performing better than others. She includes some of the assessments you're doing and then a whole host of others. So if there's one that has a signal of being able to detect, then, I would want to make sure that you included that. So I don't know if she can give you a preliminary look at those data, but I would definitely keep the subjective because, we have patients who can't find their way home, but still somehow score okay on some of these tests. So I would do both for sure.
Right.
And I think you need to specify at least how long you want patients to stay on ADT, because you may not want someone who's going to get it for 6 months if you're going to continue to follow, or I don't know how heterogeneous you want your population to be.
Yeah, I think we had proposed at least 1 year. I think that's what we had said, but that's certainly open to change as well, or feedback. Well, this is really great feedback. I really appreciate it.
So Melissa and I were talking.
This is Tony as well. I'd love to be a little bit closer to this study. I like the study design. It looks really, really cool. But I'll certainly reach on out to you, and you have me to be able to help in any way I can from the patient perspective.
Great, thank you.
Thanks, Tony.
So we were just discussing that it's possible that you might have pretty different age distributions in those 3 cohorts, and there might be something to be said about kind of having bins of age groups that fill up, so you have at least some comparability, maybe not exactly, but.
Sure, so cap based on age.
If I could suggest this, the way, so we don't drop this, Peter, that if you could perhaps send out to the group, the folks who are on the line and folks who are here, please email Peter if you're interested in participating in a working group. We'll put together some Zoom calls and begin the process of design. We'll need somebody from the survivorship, I guess.
Yeah,
Quality of
we've
life?
actually been
Survivorship?
talking quality of life and
Quality of life.
and had
Okay.
some initial
Yeah,
discussions.
Lynn Henry was actually very, very supportive.
Yeah, they're
she wanted to
very
run
interested,
this
so.
and breast cancer and endocrine therapies there. So,
Perfect.
She was very supportive.
So we'll get that group together. If you're interested, please email Peter, and then we'll start setting up some Zoom calls to put this together. This is a fabulous idea.
Great, thank you.
Great.
My goodness, what a great way to.
Sounds good.
What you got left?
So we still have 23 minutes. Do you want me to talk, or we're done?
Well, you've hit 3 over the green monster so far. So you got any more?
Oh, that's it.
You done?
We're done.
We're done. Okay. A denouement. Rick, go.
So I think some of you know, but maybe not all of you, we have term limits on the patient advocates. And it's 2 5-year terms. Technically, Tony and I have gone longer because we were grandfathered, but we both expire in April. So this is true.
Terms.
Yeah, okay, so be on the lookout for candidates for our roles, because we want people who are better than we are to replace us. So reach out if you've got questions or need help, but start looking.
Does anyone want to talk? There's a meeting tomorrow morning. The meeting tomorrow morning.
So this is a meeting to discuss rally support for 3 trials. Heather Chang's trial, the prostate cancer co-chairs are always the last. No, sorry. Ulka, right? And 19. Well, wait a minute. Oh, sorry. Wait a minute. Yeah, sorry. Here, give it to Ulka. She seems to know more than I do about this meeting. I mean, I'm speaking, but.
Okay, tell us what's happening tomorrow morning. We'll be in the Board of Governors.
Okay, so in this same room, we're meeting, at 9 o'clock is our typical renal and bladder sessions. But prior to that, at 8 a.m., we're meeting to kick off some of the studies that are starting and just getting activated. So SWOG 2200 or PAPMET 2 is one of them. The others are SWOG 1937, Tom? Yes, and there's a third one. Yes, so upper tract 2011, is that? Is the study chair here? Yeah, I know that. So you're going to talk about that, Tom? He's going to be here? Okay. And you're presenting 2011. Okay, so just come at 8 o'clock. Is there breakfast? Do you guys know? There'll be coffee at least. I don't know about breakfast. Do you know? Nobody's saying. Hey, yes, because he could not make the announcement. Okay, thank you. But hopefully see all of you at 8 a.m. tomorrow.